Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the archipelago, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after, evidence that the quality of our education meets international standards. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the archipelago, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after, evidence that the quality of our education meets international standards. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the archipelago, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after, evidence that the quality of our education meets international standards. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey. With an extensive network of partnerships and a teaching factory system integrated with the global health industry, our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the archipelago, but also on the international stage.
Okay, we would like to express our sincere gratitude for the Vice Minister, Mr. Professor Dr. Dante Saxono Herbuono, for present at this international conference. Okay, ladies and gentlemen, may I have your attention please? Before the conference officially begins, we kindly remind all participants to make sure that your Zoom display name includes your full name and institutional affiliation. And kindly make sure your audio and video settings are properly adjusted. Once again, ladies and gentlemen, before the conference officially begins, we kindly remind all participants to make sure that your Zoom display name includes your full name and institutional affiliation. And kindly make sure your audio and video settings are properly adjusted. Assalamualaikum warahmatullahi wabarakatuh. With healthy regards. Good morning, good afternoon, and good evening, ladies and gentlemen. On behalf of the organizing committee, I would like to express our sincere gratitude for your presence at this international conference. Welcome to 5th International Conference on Health Education and Technology, with the theme Chronic Complication and Their Impact on Life Satisfaction in Diabetes, proudly organized by the Health Polytechnic of the Ministry of Health Tasikmalaya. Before we begin, please allow me to introduce myself. My name is Aziza Rahma, and I'm honored to serve as your Master of Ceremony for today's conference. It's a great pleasure to accompany you through this meaningful event. The Honorable Mr. Professor Dr. Dante Saxono Herbuono, specialist in internal medicine, consultant in endocrinology, metabolism, and in diabetes PhD, Vice Minister of Health of the Republic of Indonesia. The Honorable Director General of Health Workforce, who will be represented by Ms. Anna Kurniati, Bachelor of Public Health, Master of Arts, PhD, Director for Health Workforce Provision. The Honorable Dr. Dini Mariani, Bachelor of Nursing, Nurse, Magister of Nursing, Director of Health Polytechnic of the Ministry of Health, Tasikmalaya. The Honorable Vice Director 1, 2, and 3 of Health Polytechnic of the Ministry of Health, Tasikmalaya. Our distinguished invited speakers, Dr. Muhammad Junaid Farooq, UCSI University, Malaysia, Dr. Zoang Manuel Carreras Jimenez, Magister of Public Health, University Delhi, Timor-Leste, Ms. Anjanet as the Leon Master of Art in Nursing, Registered Nurse, Central Escolar University, Philippines. Mr. Maula Ismail Muhammad, Bachelor of Engineering, Magister of Public Health, Health Polytechnic of the Ministry of Health, Tasikmalaya. Our respected moderators and session chairs, and last but not least, all distinguished participants who are joining us virtually from Indonesia and abroad. Ladies and gentlemen, allow me to present a brief outline of our program for today. First, opening. Second, listening to the Indonesian National Anthem, Indonesia Raya, followed by the Health Polytechnic of the Ministry of Health March. Third, report from the Chief Committee. Fourth, welcome and opening speeches. Fifth, keynote address from the Minister of Health of Indonesia. Sixth, plenary speech session 1 and 2. 7. Lunch break. 8. Parallel oral presentation sessions. 9. Announcement of guest speakers. And the last is closing ceremony. Ladies and gentlemen, before proceeding to the opening ceremony, let us open this conference by reciting Basmalah together. Bismillahirrahmanirrahim. May this event bring us blessings, inspiration, and meaningful collaboration. Next, ladies and gentlemen, let us listen to the Indonesian National Anthem, Indonesia Raya, followed by the Health Polytechnic Ministry of Health March. Okay, and now To begin our event, we will watch a traditional Sundanese dance performance, symbolizing the warmth and hospitality of West Java.
Synopsis title Nyaah Karaga or Love Your Body. Cancer is one of the deadliest diseases in the modern era. Although medical advances have increased life expectancy for many cancer patients, the disease remains a serious threat to many people. Lifestyle, environmental, and genetic factors can increase the risk of cancer. This creative dance performance is a call to adopt a healthy lifestyle and raise awareness about this disease, especially among the younger generation. We hope this creative dance performance can educate the public about the importance of caring for one another, supporting each other, and boosting the confidence of those affected.
Hello everyone! Let us introduce ourselves. We are from Wirasagita Raga, Poltekkes Kemenkes Tasikmalaya. We will be presenting a dance entitled Nyaah Karaga or Love Your Body. Happy watching. Thank you. Bye.
Hello everyone! Hello Miss! Today's topic is about cancer. Cancer has been around since ancient Egypt 3000 BC. Cancer is very dangerous disease, so we have to protect ourselves from getting cancer.
Thank you, Miss.
Sadness, despair, loss of direction, and trauma are the first thing people feel. However, that's not the solution to all problems. Support from those around them is crucial for the health of those infected. Love, protect, and care for yourself.
Okay, so ladies and gentlemen, we shall now continue to the next agenda, that is report from SIF Committee. And now, we will invite the SIF Committee of this conference to deliver a report. Please welcome Ms. Yanti Cahyati, Bachelor of Nursing, Nurse Magister of Nursing. Sorry, Miss, your voice is unclear.
Unclear.
Can you hear me clearly?
Yes.
Okay.
Okay, thank you. Okay, thank you. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning to everyone present. Honorable Vice Ministry of Health of Republik Indonesia, the Honorable Director of Health Polytechnic, Ministry of Health Tasikmalaya, the Honorable Vice Director 1, 2, and 3 of Health Polytechnic, Ministry of Health Tasikmalaya, respected speaker, distinguished presented, esteemed college, ladies and gentlemen. It is a great honor and privilege to welcome all of you to the 5th International Conference of Health, Education and Technology. We have gathered here today to deliberate on the significance of chronic complication and their impact on life satisfaction in diabetes. Diabetes mellitus is a global health challenge that affects 1 million of people worldwide. Its complexity requires comprehensive management and innovative strategies. The increasing prevalence of diabetes mellitus demands an integrative and multidisciplinary approach involving healthcare professionals, researchers, and policymakers from diverse fields. The conference aims to bring together experts from various disciplines to discuss the latest advance in diabetes care. The conference will focus on innovative strategies, collaborative research, and best practice that can improve patient outcome and reduce of diabetes on a global scale. By fostering cross-disciplinary dialogue and partnership, the conference aspires to pave the way for more effective and sustainable solutions in diabetic management and prevention. To delve deeper into this crucial topic, we have assembled a distinguished panel of speakers for today's event. On behalf of the organizing committee, I extend a warm welcome to Professor Dr. Dante Saxono Herbono, Dr. Dini Mariani, Bachelor of Nursing, Nurse Magister of Nursing, for welcome speech from Director of Poltekkes Tasikmalaya, Maula Ismail Muhammad, Bachelor of Engineering, Magister of Public Health, Politeknik Kesehatan Kemenkes Tasikmalaya, Prof. Muhammad Junaid Faruh, UCSI University Malaysia, Dr. João Manuel Correa Ximenez, Magister of Public Health from University Dili Timor-Leste, and Miss Anjanette S. Delon, Registered Nurse from Centro Escolar University Philippines. This conference was hosted by UCSI University Malaysia, Centro Escolar University in the Philippines, University Dili in Timor-Leste, Poltekkes Kemenkes Palu, and Stikes Cirebon. We are deeply grateful to this eminent scholar for sharing their insight on this subject. And I would also like to this opportunity to express my heartfelt gratitude to the Honorable Ministry of Health for accepting our invitation and for their continued support and guidance. My sincere thanks also go to our director for encouraging us to organize this significant event and for their invaluable suggestion throughout of the planning process. The conference was attended by participants for various institutions across Indonesia and abroad. Representative include staff and students from Pajajaran University, 11 Maret University, University Katolik Widya Mandala Surabaya, Universitas Mula Warman, Stikes Medika Seramoe Barat Melaboh Aceh Barat, Stikes Cirebon, Politeknik TIDC Bandung, and Poltekkes campuses across Indonesia. Our international colleague joined from UCSI University Malaysia, Centro Escolar University Philippines, and University Dili in Timor-Leste. Their diverse perspective enrich the discussion and foster collaboration across borders. As we conclude that 5th International Conference on Health, Education, and Technology, I would like to thank all speakers, co-hosts, participants, and supporters who have made this event a success. Your dedication and insight on chronic complications and their impact on life satisfaction in diabetes have been invaluable. Let us continue to collaborate and innovate in the pursuit of better health outcome for people living with diabetes. We encourage each of you to apply the knowledge gained here to your respective field and to stay engaged with our international community. We look forward for welcoming you or our next conference. Until then, thank you for your participation and Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam. Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Ms. Yanti, for your report and dedication in arranging this event. And now, thank you, Ms. Yanti, for your report and dedication in arranging this event. And now, we will listen together welcome speech from Director of Health Polytechnic of the Ministry of Health Tasikmalaya. We are honored to invite Dr. Dini Mariani, Bachelor of Nursing, Nurse Magister of Nursing, to deliver the welcome speech. To the Honorable Dr. Dini Mariani, the time is yours.
Okay, thank you, Aziza. Can you hear my voice clear? Clear?
Yes, clear.
Okay, thank you. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. May peace, mercy, and blessing be upon us all. The Honorable Vice Minister of Health of the Republic of Indonesia, Bapak Profesor Dr. Dante Saxono Herbuwono, Intern Specialist KMD, PhD, distinguished keynote and invited speakers, distinguished guests, researchers, educators, practitioners, and all participants, ladies and gentlemen. It is a great pleasure and a distinct honor for me, on behalf of Poltekkes Kemenkes Tasikmalaya, to welcome you all to the 5th International Conference on Health, Education, and Technology. We are deeply grateful to see such a diverse gathering of professional and academic from Indonesia and across the world, united by a shared purpose to advance knowledge, innovation, and collaboration in the field of health education and technology. This year's conference carries a powerful and relevant theme, chronic complication and their impact on life satisfaction in diabetes mellitus. Diabetes mellitus continue to be a major global health issue. One, the challenge not only our healthcare system but also our compassion and creativity as health professionals. Chronic complications such as cardiovascular disease, neuropathy, retinopathy, and kidney failure not only shorten life expectancy, they also profoundly affect the daily lives, productivity, and overall life satisfaction of individuals and families, of course. Through this conference, we hope to deepen our understanding of these issues and explore innovative multidisciplinary solutions in which education technology and research play central role in promoting prevention, early detection, and improved quality of life for those living with diabetes. We are deeply honored by the presence of Vice Minister of Health, Republic of Indonesia, whose dedication and vision continue to inspire the transformation of Indonesia health system toward equity, innovation, and resilience. We also extend our sincere appreciation to all of the director and the general of director in workforce provision for her continued guidance and for their continued guidance and support in developing competent and compassionate health professionals across the nation. We are equally delighted to welcome our distinguished speaker who have graciously joined us in this important event. Dr. Muhammad Junaid Farouk from UCSI University Malaysia, Miss Anjanet S. de Leon, MANRN from Centro Escolar University de Philippines, Mr. Dr. Joao Corella Simenes, MKM from Universidade Dili Timor-Leste, and Mr. Maula Ismail Muhammad ST, MKM from Poltekkes Kemenkes Tasikmalaya, Indonesia. Your expertise, experience, and insights will greatly enrich our discussion and inspire all participants to strengthen their contribution in health education and research. I would also like to express my heartfelt gratitude to the organizing committee, all faculty members, and our academic and institutional partners who have worked tirelessly to make this conference possible. Your dedication and teamwork truly reflect our shared commitment to excellence and collaboration in the service of health and humanity. Let this international gathering be a platform for networking, innovation, and meaningful exchange, where new partnerships and research ideas are born to address real-world health challenges. Ladies and gentlemen, as we embark on today's session and discussion, let us be reminded that the work we do here goes beyond academic achievement in touch lives. Through our research, teaching, and service, we have the power to improve the quality of life, to empower patients and communities, and to shape a healthier and more hopeful future for all. Once again, on behalf of Poltekkes Kemenkes Tasikmalaya, I warmly welcome all of you to the 5th International Conference on Health Education and Technology. May this conference be fruitful, inspiring, and impactful for everyone involved. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Dini, for your warm welcome and inspiring words. Okay, ladies and gentlemen, for the next, we will listen together the keynote speech from Vice Minister. Ladies and gentlemen, we are deeply honored to have with us the Vice Minister of Health of the Republic of Indonesia, Professor Dr. Dante Saxono Herbuono, specialist in internal medicine, consultant in endocrinology, metabolism, and diabetes. Please welcome Mr. Professor Dr. Dante Saxono Herbuono.
Hello, good morning, everybody. Thank you for inviting me to share about diabetes today. That belonging of the Poltekkes Kemenkes Tasikmalaya. I will share my speaking keynote speaker with my slide here, and because this the very important to know about diabetes in the halls. So I would like talking about not only diabetes but previous become diabetes as a uh, pre-diabetes. Sorry, something happened with my computers. Yes, this is pre-diabetes. Yeah, pre-diabetes is the place before we have a diabetes. You know, in diabetes is very simple to explain all of us. If you eat something and the blood glucose entering your body, the blood glucose is distributed to all the organ and entering to the cells in the livers, in the muscle, in the fat, in the fat, by using the scenario of the pipe we call as insulin. In the people with diabetes, the insulin cannot work properly, so that's why blood glucose in your body cannot enter into the cell as a source of energy. So that's why if you have diabetes, if you check the blood glucose is very high in the circulation, it because diabetes cannot entering to the cell. If the cell cannot have blood glucose as a source of energy, the cell will be destroyed. So that's why you have a complication, like complication in the muscle, complication in the kidney, complication in your heart, muscle, as we call as a cardiomyopathy and etc. So that's why it's very important to entering the blood glucose to your cells. And then now Indonesia is the fourth number in the world have diabetes. 1 in 8 people in Jakarta already become diabetes, and uh, surprisingly, thirds or 30% of people in Jakarta have prediabetes. So if I know today you inviting this conference is about 500, it's mean 60 people of them have diabetes. Very hard disease. So, and then diabetes is very important because 3 million people dead because of diabetes, more than 1 million amputation caused by diabetes, 500,000 people have a new kidney failure because of diabetes, 300 cases of blindness, new blindness is caused by diabetes, and the cost to take care of this complication is more than 150 billion directly care loss. We also now indirectly care costs because they cannot work properly to suffering the family to if they should make amputation, for example. If they are the taxi driver cannot driving again the car because they have complication like amputation in because of diabetes. So diabetes is very important. The diabetes drama is already taking its toll, and the epidemic is growing very fast all around the world, especially in this uh, developing country like in Indonesia. So, what actually people say as diabetes? I just want to let you know you just only should remember two number. If you check the blood glucose as fasting plasma glucose, you just only remember more than 126 milligram per deciliter. And oral glucose tolerance test of 4 post not fasting diabetes measurement is 200. So uh, if you accept the number of 126 and the fasting blood glucose and not fasting 200 for blood glucose getting the result, you can say that people have diabetes. But diabetes is not very fast disease. It should have a process. Not people today normal and tomorrow become diabetes. So this is some place and taking a role, but people before diabetes have condition as we call of pre-diabetes. I want to let you remember two number again, 100 and 140 or 40. If the people have more than 100 but below of 126 in fasting and postprandial 140 but less than 200, they call as prediabetes. It's very important to measure the people, it's knowing the people as prediabetes because it's already have diabetes. Actually, they already have their own complications. So prevention is very important to prevent people with prediabetes to become diabetes in the near futures. And ladies and gentlemen, the diabetes is very important. So you should know people with prediabetes. What actually the struggle of diabetes is, who is the high people with the high risk of prediabetes. They have some ethnic special in Indonesia have diabetes itself. We already have surveillance of genetic survey in Indonesia, and we found some people with specific ethnic have diabetes, and also body mass index, that where people with a very high birth index is also can become diabetes if they cannot reduce the body weight. Lack of activity is also risk of diabetes, and also the diet. This is very important. So ethnic, I will show you the people with ethnic in Sulawesi, South or North Sulawesi have a people with the highest risk of diabetes in Indonesia. If we already know as a prediabetes, actually you can prevent yourself not become diabetes in the futures. This is one of the sign of prediabetes people we call as acanthosis nigricans. If you have in this picture, if your back of neck have a line colors, this line color, maybe you have pre-diabetes. So after this, you check your friends, your family. If they have a line like this, maybe they have a pre-diabetes condition. So go to the laboratory and check the blood glucose. Ladies and gentlemen, the periodically examination of laboratory is very important and important key to prevent people with prediabetes not to become diabetes. Why? So why is prediabetes is very important to become diabetes if actually the taking care of diabetes is not only to reduce blood glucose itself, but the most important is to prevent of complications. The topic today webinar is to prevent and have a quality of life people with complication of diabetes. So very important to know pre-diabetes condition before you have diabetes in the futures. So diabetes this is the sign of diabetes. They are easy to become hungry, frequency of urination, and airways thirsty. This is a conventional sign of diabetes. But sometimes it's not very clear because some sign like always tired, frequency, sudden weight loss, one that one healing, and sexual problem, blurry vision, vaginal infection, numb or tingling hands and feet is also sign of the hidden sign of diabetes. So that's why diabetes is very important because 75 to 8%, 80% people dead because of diabetes. The risk factor of diabetes increasing to people to become heart problems. And not only heart problem, why is have a heart problem? If you have here the vessel in the coronary sign, if you have diabetes, the capacity of flow in your coronary is more and become less or because of the plaque is more easier in the people of diabetes in your coronary. That's why the people with diabetes sometimes have also have a high level of cholesterol, and if that's combination we can have a more risk factor people to become complication in the heart in the near future, not too long to become a problem in the heart. And a kidney problem, the most people in the hemodialysis clinic, it caused by diabetes and hypertension. You will see here more than 40% of people with a kidney failures is caused by diabetes. So diabetes make a key role to prevent people who have become kidney problem in the futures. And then also eye problems. There are two kind of the eye problem that can become of the people with diabetes. First is stuck of the vessel, and second is bloody in the retina. So this is a very important. So that's why people with diabetes have sometimes a blurry vision. It's not because of only because of the vitreous humor vitreous in the eyes is become more sticky, but also it's because of vessel in your retina is have a problem. And then diabetes also have tend to become complication in your leg. This is a sample of leg with people with diabetes start with the problem in the nails and sometimes with this callus and sometimes with the inflammation and the very worst one to become people like this. They are gangrene in people with diabetes. And why it can become that like that is because of the vessel is in people with diabetes in the leg is also destroyed, so the blood cannot entering in the vessel in the your leg, because leg in the higher long way from the heart vessel in your body. Some people, if they already have diabetes, easy to become stuck of blood entering to the leg, and they can become not easy to wound healing and become gangrene. And another thing is dysfunctional actions is I can say that action dysfunction can become 10 years more easier in people with diabetes. So pre-diabetes is very important, and diabetes is very important because every 10 seconds, one people die because of diabetes. So still now, you still have a risk in diabetes. We already have a genetic survey in Indonesia, and we found the all people in Indonesia actually have the genetic factor of diabetes. So are you risk in diabetes? You should control, start yourself and your family to go to the laboratory and check you are in the condition of pre-diabetes or diabetes, because you already have the story in your genetic pattern of tend to become diabetes in the futures. And I call this is very important because diabetic genetic spike net phenomenon is very close with us because of married people with diabetes risk and people with diabetes risk to make the diabetes genetic spider net phenomenon is more closer in not far from you. So talking about diabetes is talking about the genetic pattern and the number of diabetes. I believe it will be increase the number in the near future. What you should to do is to make to become healthy and evaluation regularly in yourself. So detection is more easier than treating diabetes. It's very important. So that's why that is that I can share to you today. I hope this uh, presentation can have delivered the topic that will be present with the experts, the next expert in this webinar that belong of Kemenkes Poltekkes Tasikmalaya. Thank you so much for your attention.
Okay. Thank you, Mr. Vice Minister, for your forward-looking message regarding diabetes care and life satisfaction. For the next, there will be a certificate presentation which will be given by the Director of Health Polytechnic of the Ministry of Health Tasikmalaya. To the Honorable Dr. Dini Mariani, you can give the certificate, please.
Okay, thank you, Aziza. Okay, thank you for Your Excellency Prof. Dr. Dante as Vice Minister of Health of Republic of Indonesia. On behalf of Poltekkes Kemenkes Tasikmalaya, we are honored to present this certificate to appreciation for your inspiring keynote speech at ICHET 2025. Thank you for your contribution and dedication to advancing health education. Thank you.
Thank you.
Okay. Before we move to the next session, we would like to kindly invite the Vice Minister of Health of the Republic of Indonesia, the Director of the Health Polytechnic of the Ministry of Health Tasikmalaya, our speakers, and all distinguished participants to please turn on your cameras for a group photo session. Once again, I would like to kindly ask all distinguished participants to please turn on your cameras for a group photo session. Okay, let's capture this wonderful moment together, and our technical team will guide us. Please keep smiling, everyone. For the first slide, 3, 2, 1, smile. Okay, for the next slide. Ready? 3, 2, 1, smile. Okay. Ladies and gentlemen, we are now entering plenary session of today's international conference on chronic complications and their impact on life satisfaction in diabetes. Please remain in this main room Zoom as we begin the plenary presentations, which will be featured our distinguished speakers from Indonesia, Malaysia, Timor-Leste, and the Philippines. And before we begin, allow me to introduce our moderator for this plenary sessions. Okay, there will be a CV. Okay, her name is Miss Kanita Wulandara, Magister of Midwifery. Ms. Kanita is a lecturer of midwifery at the Health Polytechnic of the Ministry of Health Tasikmalaya. She also serves as the secretary of the Ethics Committee and as a member of the Language Development Unit at the institution. With her strong background in midwifery education, research, and community engagement, she has been actively involved in supporting academic collaboration, facilitating language workshops, and assisting ethical review processes for research projects. We are delighted to have her as the moderator for this session. So, ladies and gentlemen, without further ado, please welcome Ms. Kanita Wulandara.
Okay, thank you very much, Aziza, for the kind introduction, and good morning, everyone. A warm welcome to all participants that joining us from Indonesia, Malaysia, Philippines, Timur-Leste, and other parts of the world. I'm Kanita Walandara, and it's a great pleasure to be your moderator for this international conference on technology, health, and then we have theme chronic complication and their impact on daily life satisfaction in diabetes, hosted by Health Polytechnic Ministry of Health Tasikmalaya. Today, we will learn with 4 amazing speakers who will share their valuable insight about diabetes management, chronic complication, and also how we can help people to live better, healthier, and happier lives. We have 2 plenary sessions, and each session will feature 2 invited speakers. And after both speakers have delivered their presentation in each plenary session, we will continue with discussion and Q&A session. So please stay tuned and feel free to share your question in the chat box during the presentation. I believe that today's discussion will inspire us to think creatively and collaboratively about improving diabetes management and enhancing the quality of life for people with chronic complication. So let's enjoy this inspiring session together, and don't forget to stay active in the discussion. Without further ado, let's begin our plenary session 1. In plenary session 1, I have 2 invited speakers who will talk about how technology and pharmacological approaches can improve life satisfaction among people living with diabetes and chronic complication. But before we begin, let me ask you this. Have you ever wondered how your health data like blood sugar records, daily steps, or even sleep hours can actually help doctors and policymakers make a better health decision? Well, that's what our first speaker will explore today. Please welcome Mr. Maula Ismail Muhammad, Bachelor of Engineering, Magister of Public Health from Health Polytechnic Ministry of Health Tasikmalaya. All right, here is the CV. I will read the CV first. Mr. Maula is currently working at Health Polytechnic Ministry of Health Tasikmalaya as a lecturer for Diploma Medical Record and Health Information. He has strong experience in managing health data system and developing computer-based health program to support better public health services. And today, he will talk about harnessing big data and digital health analytics to understand and improve life satisfaction in diabetes with chronic complication. Mr. Maula, are you ready?
Yes, okay, thank you, Miss.
Now let's listen to his presentation, and Mr. Maula, time is yours.
Okay. Can my voice be here in clear? Miss?
Yes, it's clear.
Okay. Wait a second. Let me share my screen first. Okay, wait. Can you see my slide? Miss Konita? I'm sorry. It's my slide is showing?
It's showing, yes.
Okay. Okay. Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Today, I will be presenting my ongoing research. I'm currently working in harnessing big data and digital health analytic to understand more about diabetic and its complication. The context for this research from persistent burden of non-communicable disease in Indonesia, of course. That's maybe already presented by early speaker, the keynote speaker, Vice Ministry of Health, Dr. Dante, that diabetes is very dangerous. Uh, but in previous studies that I found, it's only highlight what it's called between two single variable, glucose, complication, social factor, and glycemic, and so on. There have not been many studies that segment diabetes patient dimensionally covering socio-demographic, clinical, mental disability, and quality of life. Crucially, the heterogeneity of health risk within the population necessitated a paradigm shift from universal health program to more targeted intervention. Uh, and I see with the advancement of the data analytic, maybe a clustering method now enable identification of diabetic subgroup based on this diverse socio-demographic and health characteristic that
Mr.
maybe
Maula,
yes.
I'm sorry to interrupt you, but your screen is not slideshow yet.
Oh, okay.
Yeah.
Okay.
Yes.
It's okay.
Yeah, it's
It's
clear now.
on second screen introduction.
Oh, it's come back to the previous one. It's not full screen.
Oh, okay, okay, but it's fine, it's fine. But it's on introduction, right?
Yes.
Okay. Uh, okay. This study introduced a data-driven approach to reveal the multidimensional profile of people with diabetes in Indonesia nationwide, providing a foundation and for more targeted and effective health policy. Okay. Okay, it's on next slide. Uh, okay. Oh, okay. So please from the ICHET. Okay, I have to stop this. Okay, gimana? Okay, please. Yeah, okay. Wait.
Yeah, you can
Okay.
continue.
Okay, sip. Let's continue. In my research, our objective is to describe the clustering pattern of diabetes patient based on variable related to demographic, quality of life, disability, mental health, oral, and chronic complication. The data was obtained from SKI, Survei Kesehatan Indonesia, and the latest are in 2023. Next, next, next slide. Okay. The research concept is on diabetic and its determinant. Uh, it's from our understanding, is from literature. We find that quality of life, mental health, disability, dental problem, and chronic complication is related to diabetes mellitus. Demographic factors such as rural, urban, male, female, education level, employment or occupation, and the quality of life is talking about seeing, hearing, uh, ability to walk, etc. And mental health is about depression and other uh, mental health issue. Okay. Uh, from the SKI data, okay, I cannot find. Okay, next slide. Okay, next slide. Okay, that was the research concept. Okay, next slide. Okay, our methodology was the study used a descriptive quantitative approach and a data mining method based on Kamin clustering algorithm that perform using R version 4 and with Facto extra library for visualization and cluster validation. Population are all respondent with diabetes mellitus age 18 to 59 years in Indonesia in 2023. Okay, of course, it's from SKI 2023 micro dataset and have complete information on diabetes status and relevant determinant variable for clustering analysis. Next. Okay. For clustering analysis, we employ KDD framework. It's to first to selection the data, pre-processing, transforming, applying the algorithm, and interpretation gitu. On data selection, we examine the SKI 2023 microdata that we have obtained from BKPK. We only select respondent that age 18 to 59 years and they has diabetes status. We also selecting variable according to our concept, our research concept, disability, mental health, and chronic complication. Next, we process, we clean, we validate before back slide, please. Okay, previous. Okay. We also see the variable if this variable is with more than 70% of data completeness. We return for further analysis, and later respondent with missing value on a key variable will be excluded from the final clustering analysis. After that, we scale the data, all the variable we scale to prevent scale bias, and later we implement optimal cluster number with elbow and confirm it with silhouette method, and we employ Kamin clustering to group the respondent, and later on in the last method we interpret the result. Next. From micro data set around 100,000 more, the 8,992 is obtained to our analysis. This analysis unit is individual, not in kabupaten on province. So this is in individual unit analysisnya. It consists of education, gender, urban rural, occupation, comorbidities, and quality of life. Quality of life is in SKI. From the questionnaire, it's asking about the ability to see, ability to hear, ability to walk. Okay, next. From the data, we first use elbow method to show the cluster in this picture over the top. We use elbow first. On the elbow, we cannot exactly see how many cluster, how many segment, or how many subgroup we can achieve by the data. It's only maybe around here, around 7, but it's not clear yet. The elbow method. So we implement a second method to find optimal cluster with silhouette method. So this method show us 7 optimal cluster for this data. Okay, next. Nah, from the cluster that we obtain, its largest cluster is in cluster 5 and 6. The smallest is in cluster 2 and cluster 4. With comorbidities, with center dominant characteristic, we see in the centroid cluster. So K-mean clustering is the method for K-mean clustering is the algorithm is to create a circle spare in 15 dimension. It's most likely spare spare around all data that exists. The K-mean clustering, he create optimum cluster so that all data can divide to each cluster. This dominant characteristic is the center that we can see from this center, the center from the position from the steroid where its dot is present. Nah, from the centroid, we see that in cluster 1, it is represent lower socioeconomic population. The dominant characteristic can be seen in this column. In cluster 1, we see that it is represent lower socioeconomic population with limited access to healthcare service. In cluster 2, this is the most burden cluster. It is grouped with heavy comorbidity and highest health risk. In cluster 3, what's called? It's the group with best socioeconomic status and best health condition. In cluster 4, we see diabetic patient experience as low mental quality of life and psychosocial. And cluster 5, 6, 7, it is a larger group with relatively stable physical and mental health condition. Cluster 6 is self-employed, wira swasta, maybe we call that. Cluster 7, it is the one that say other occupation, including not school, unemployed, and other. Okay, that's our result finding. Next is discussion. We see that from the cluster results show high diversity in the condition of people with diabetes in Indonesia. We see that cluster 2, its only size is about 1.42% in size respondent, but it has the highest disease burden, kidney and heart disease. But this is in line with finding on Elendu and Pandey that diabetes and heart disease had a relationship and exchange in through complex inflammatory and metabolic mechanism. In cluster 3, we see that positive influence, most of them have positive influence, education and professional employment on diabetes management. So from other research, we see that a higher level of education with greater, maybe he get greater awareness of healthy lifestyle. He had greater medication knowledge, and he the one that have better access to health service. So the cluster 3 is like a positive cluster. In cluster 4, the size is around 5%. This is had mental and disability. Mental is like disability is seeing, hearing, and walking. This is had that disability issue. This also confirmed with other research. Person with diabetes have a higher risk of depression in the general population. And we see in that psychosocial intervention and patient education can contribute significantly to improving health-related quality of life. Next. Next slide, please. Previous slide. Okay. Next, we talk about socio-demographic. We talk in cluster 1 are the group that has low education and low skill for low education job, such as fishing, labor, manual labor, buruh. We call in Indonesia buruh, that mostly on rural area. Our cluster also show that even not on height average, its centroid, its scope centroid is in comorbidity, disability. Maybe it is not as high as other in previous uh, cluster 4 or cluster 2, its comorbidity was there. Low level of education and rural location is one of the indicator of limited access to health information, medical facility, and early screening for diabetic. This finding aligned with the research of Kurniawan, which show that the prevalence of diabetes in rural area is bigger than the urban. In contrast with that, we see in cluster 6, it show a relatively good health profile. The cluster 6 dominant characteristic from its centroid is that that person in that cluster is self-employed, male. Maybe we see that as a potential for success diabetes management through lifestyle-based intervention and the strengthening of preventing program. Engaging in meaningful employment can foster structured routine that support adherence to healthy behavior, including regular meal time, consistent medication intake, and physical activity. Okay, next, the last one. We also see that this study have limitation. First is this study relied on secondary data. It's from SKI 2023. It's from cross-sectional data, which inherently limits over variable selection and measurement precision. Its limitation is maybe standard if we conducting research from secondary data. Next, the dependent variable used to identify diabetes case was based solely on respondent self-report that they had been diagnosed with diabetes. On the questionnaire, we see that not all of the self-report diagnosis is checked with its biomarker confirmation. Therefore, potential recall bias and misclassification cannot be completely ruled out, and future research should be incorporate objective diagnostic data to strengthen our research validity. The result of the clustering analysis only indicate group between variable within each segment. It means that it cannot show causal conclusion, like in maybe cluster 6 that 6, 7 that the cluster is mainly its centroids. It's mainly for respondent that self-employment, that more stable occupation, but we cannot say that that is the only one factor that cause the diabetic to cannot occur. It's the clustering. Our research is not talking about causal conclusion. It's only describing that from our cluster we can say that cluster 1, cluster 2, cluster 3, and so on. Last slide. Our conclusion that the application of the Kamin clustering method it identified 7 group with diabetic with multidimensionality characteristic. This segmentation or this cluster can provide more understanding of more characteristic variation, health condition, and quality of life of people of course, with diabetes in Indonesia. Okay, next. I believe it's finished. Okay, thank you. I'm returning to moderator.
All right. Thank you so much, Mr. Maula, for showing us how digital innovation and data can truly make a difference in improving healthcare services and also people satisfaction. To all the audience, if you have any question to our speaker, please feel free to drop them in the chat box. We will address them later during the discussion session. Now, we will move to our second speaker. Our second speaker will talk about pharmacological intervention for chronic diabetes complication, how to improving outcomes and life satisfaction. I want you to imagine first. Imagine if you have to take medicine every day for a chronic condition, and how even a small improvement in treatment can change a patient's quality of life. What do you feel? That's exactly what our next speaker will share with us. And I'm very glad to welcome back Dr. Junaid Farouk from UCSI University, Malaysia. Dr. Junaid, are you here with us?
Yes, good morning. Can you hear me?
Yeah, I can hear you. But your voice is a bit low.
Is it okay now?
Yeah, it's better. All
Sorry,
right.
I have a flu also,
As we can
so
see
I'll try
in
to speak louder.
the CV, actually, I'm personally delighted to meet you again, as we already had the pleasure of having you as one of our distinguished speakers at ICHET last year. And it's wonderful to have you return and continue sharing your valuable insight with us. I will read your CV first. So, Dr. Junaid is a clinical pharmacist with over 10 years of experience in both hospital and also academic settings. He holds a PhD in clinical pharmacy from University Kebangsaan Malaysia and currently serves as assistant professor and head of practice, industry and community engagement at UCSI University. Wow, he has published more than 50 scientific papers, served as an editor for PLOS ONE and Nature Scientific Reports, and he has received multiple awards, including Best Teaching Awards and Research Excellence Awards. Ladies and gentlemen, let's warmly welcome Dr. Muhammad Junaid Farouk to deliver his presentation about pharmacological intervention for chronic diabetes complication, improving outcomes and life satisfaction. Time is yours.
Thank you. Thank you for the kind introduction. I'll share my screen now. Okay, so good morning, everyone, and my name is Dr. Junaid. So today I will talk about the pharmacological advances and personalized medicine in diabetic management. So we all know that over the years, diabetes is still one of the non-communicable diseases, which is still prevalent, and day by day, the cases are still increasing. So what can be the strategies by which we can, improve the quality of life and lifestyle of the patients, and also those patients who do not have diabetes, they are at the risk of developing diabetes. So what kind of interventions can be done to control their diabetes? And those patients who have already developed diabetes, what are the drugs, or especially the newer classes of drugs, which can reduce the complications, the diabetic complications? So today we will discuss into that. So let's start with the general introduction. So we already know that between type 1 and type 2 type 2 diabetes is more prevalent. As you can see, it is up to 95% of the patients. Whereas type 1 diabetes, although it is severe also, but it comprises up to 5 to 10% of the patients. And then if we compare between the management, so of course type 1 diabetes solely have to rely on insulin, whereas type 2 diabetes, the earlier we detect it, it can start with the lifestyle modifications, exercise, oral medications, and in severe cases, we can also use insulin. So here we have a great margin to play with, uh, educational intervention and motivation for the patient. So we can treat them better, we can provide them a better and tight glycemic control, and we can also prevent their complications. Okay, so the rise of diabetes and the need for the better management. So again, this is to remind us that how this disease is growing worldwide, what is the prevalence. So over 537 million adults worldwide are suffering from this disease, and it can lead to serious complications. So it's not only about the high blood glucose level. So this high blood glucose level can affect our other vital organs as well. So when patient sign and symptoms are not controlled, maybe due to non-compliance, patient is not taking the medication properly, or maybe misdiagnosis. Patients are not really diagnosed with diabetes, or they are pre-diabetic and they continue their sedentary lifestyle. So it can lead to serious complications, and as a result of these uncontrolled symptoms and disease complexity and complications, their hospital admissions will increase, and the overall burden, or you can say the cost of healthcare, will be increased. Okay, so here we can see that the vital organs which can be affected by uncontrolled blood sugar levels are your kidneys, your brain, eyes, heart diseases, and also loss of toes, feet, or leg in severe condition, starting from normal uh, neuropathy, and then if patient has wound or cut, then it will be difficult for the patient to recover quickly as a complication of the diabetes, like developing gangrene and other complications. Okay, then narrowing down to the treatment options. So all of these drug classes, we know them since ages. They are like quite well established. Then what is wrong? Why still those patients who are already diabetes, they still move towards the complication? Is it the choice of the drugs? We are still relying on the old drugs like sulfonylurea, glutamate. Of course, metformin is still the gold standard and the first line therapy. So what about the newer agents? What are their pros and cons? So today we will discuss into that. Okay, so here we can see that, of course, type 2 diabetes patients, majority of them will be having metabolic syndrome. They will be having obesity. So in such cases, your sulfonylurea, your glutamate, they already have side effect of weight gain. So which limits their, you can say, utilization or preference in such kind of population. Also, your thiazolidine they also have side effects of weight gain. Okay, then we are left with what options? Metformin, your DPP4 inhibitors, GLP-1RA, and SGLT2 inhibitors. So, question is, how do we choose these drugs after patient is newly diagnosed with diabetes, or they are already a diabetic patient but might not be responding to the current therapy? Their HbA1c is still not under control. Fasting plasma glucose is still not under control. So, as per the latest International Diabetes Federation Global Clinical Practices Recommendation of 2025, so here we can see that we can always start the patient at diagnosis with metformin, and lifestyle modification is mandatory. We cannot skip the lifestyle modification for the patient, because this is not a magical pill that patient keep on eating all those junk food, high calorie diet, and we can expect the metformin to do some magic for them. No. So patient counseling, patient education, and lifestyle modification should always come at number one. Okay, then metformin will be the first choice at diagnosis, and then the second choice of the drug will be depending on patient comorbidities. So as per the recommendation, if patient has heart failure or kidney disease, SGLT2 inhibitors are preferred for the second drug. And if patient has obesity or atherosclerosis disease like high cholesterol, uh, cholesterol level is high, coronary artery disease secondary to high cholesterol, then GLP-1 receptor agonists, they are the drug of choice. So this means that we have to individualize the drug based on the patient comorbidity. We cannot set a random drug for the patient. So it always has to look into patient individualization. What are the lab parameters of the patient? What are the other drugs? Is there any drug-drug interaction between these drugs or not? So based on this, now there is a shifting landscape of care. Previously, we used to focus on the glycemic control, glycemic central, where our primary goal was only the sugar control. But now it has moved towards the patient-centric goal, which is holistic care. What is holistic care? That not only we have to manage the glycemic control, as well as we have to protect the patient vital organs. We have to manage patient weight and also reduce the risk of major complications. Okay, so in order to do this, the key pharmacological advances which we have these days are SGLT2 inhibitors, which promote urinary glucose excretion, and they have cardiovascular and renal protection effect. Then we have GLP-1 receptor agonists like your semaglutide, liraglutide. They enhance the insulin secretion, and specifically they are used for weight loss purpose. And then we have newer generation of drugs which are dual or triple agonists. So they work synergistically, involving multiple pathway or multiple mechanisms. And they not only give the improved glycemic control, but also reduce the metabolic outcomes and cardiovascular complications also they reduce. Okay, so these are the other effects of SGLT2 inhibitor other than controlling just the blood sugar levels. They have cardioprotective effect, they have renoprotective effect, they reduce the vascular stiffness, improve endothelial function, and also they improve the energy process. So that's why SGLT2 inhibitors, they are preferred for those patients who have heart failure or other cardiovascular comorbidities. Okay, so these are our drugs, all those dapagliflozin, then canagliflozin, empagliflozin. Previously, 5, 6, 7 years ago, empagliflozin was considered as, you can say, a safer drug or with higher efficacy to treat the heart failure cases or cardiovascular complications. But over the last 5 years, more clinical trials has been done, and we have this recent systematic review and meta-analysis just published in 2025, comparing the safety and efficacy of all these drugs. And we can see that canagliflozin is now ranked as #1 in reducing the all-cause mortality, cardiovascular deaths, and all-cause hospitalization for the heart failure specifically, and renal dysfunction. So you can see in terms of ranking, this drug has shown to be more superiority as compared to other agents. But this does not say that empagliflozin is not really a drug of choice anymore. So again, it depends on your country setting, the cost effectiveness. But if you have canagliflozin available, the recent data supports its superiority over other drugs. Okay, then these days, this glucagon-like peptide is getting popularity these days for its weight loss potential, not only in diabetic patients, but also in non-diabetic patients or pre-diabetic patients who are obese. So even it is being used by social media influencers or our celebrities. When you suddenly see celebrity and after 3, 4 months, they are totally shrink. So have they undergone bariatric surgery or this glucagon-like peptide? They are using GLP-1 agonist. So these are the first drugs approved to lower the blood sugar level. And then it was also identified that they can also be used for weight loss purpose. So what is the mechanism behind it? How they help in weight loss? They promote the fullness, which means appetite suppressant, slows down the digestion process, and they curbs the craving. Patient or the person don't really crave for food. So we have various drugs in this class, like semaglutide is there, liraglutide is there, and this tirzepatide, which is the dual agonist, is also there. And because of its high popularity these days, there was a worldwide shortage of these drugs also. So this also, you can say, uh, creates a question in our mind that those patients who are really diabetic, this drug should be preferred for them, or those who are just trying to lose weight or improve their lifestyle, and as a result of impulse buying, they are buying it in bulk. So this drug might not be available for the actual patients. So this is the thing which the healthcare professional has to think, and based on the stock availability, prioritize this drug for those patients who already have diabetes, rather than using it for cosmeceutical purpose. Okay. Other than this drug has also shown to be effective for its anti-inflammatory effect. Like some clinical trials have shown its efficacy in rheumatoid arthritis, psoriatic arthritis, and osteoarthritis as well. Not only this, if we see the overall mechanism, so this drug not only regulates the blood sugar level, not only have anti-inflammatory action, also it has effect on the brain. So some studies have shown its efficacy in Parkinson's disease and Alzheimer's disease, also in reducing the cravings, be it food cravings, which we all know that helps in the weight loss, but also those patients who are addicted to alcohol and nicotine. So the cravings in the brain center for these drugs, so GLP-1 agonist can help to reduce those cravings as well. And the cardioprotective effect and weight loss effect is already well known for these drugs. So this drug, just GLP-1 agonist, it is a promising drug not only to control the blood sugar level, but also for its anti-inflammatory action and its effect on the brain. Okay, so here we can see a comparison of hospitalization for stroke, heart attack, and heart failure. So basically, how well this drug is for the cardiovascular diseases. So we can see that it reduces up to 44% decline of hospitalization, showing its great importance to treat the CVS disorders as well. Okay, so these are all our famous GLP-1 analogs. The oldest one was dulaglutide. When it was released, it was really a remarkable invention, that once weekly dosing, very convenient for the patient, and also it was a non-insulin injectable. So it really gained popularity. But after that, in 2017, when semaglutide, Ozempic, was launched, so apart from its lower sugar, glucose lowering effect, it was a side effect that it is doing a weight loss. And that's why after that, in 2021, same semaglutide, it was launched by the brand name of Wegovy, but its FDA approval or main indication was specifically for weight loss. So you can see two same ingredients, but different brands and different preferred indications. And then in 2022, this trizepatide injection, which is dual analog by the brand name of Manjaro, is also in very popular these days because of its dual action and synergistic effect. So later on, I will show you the comparison. So Ozempic, semaglutide, mainly for type 2 diabetes, but also can help in the weight loss. Then Wegovy, also semaglutide, but preferably, or you can say mainly indicated for weight loss purpose. Then our tirzepatide, which is the dual GIP and GLP-1 analog, it helps in both weight loss as well as in cardiovascular conditions. Okay, so this is the overall comparison of GLP-1 agonist. So here, the difference which I would like to share with you, because the question comes in mind, semaglutide and the Wegovy and Ozempic, if both have same ingredient, how come Wegovy provides better weight loss control? So the answer is its dosing. The maximum dose of Ozempic is 2 mg, whereas for Wegovy, it goes up to 2.4 mg maintenance dose. So that's why it produces more weight loss effects. And then for the Manjaro also, it is significantly improved the weight loss because of its dual action. And if you see in this whole GLP-1 agonist, we also have oral form of GLP-1 agonist, oral form of semaglutide, which is Rybelsus. So I will talk about this also. So here you can see just an overview of the how is it like the duration or course of treatment of Wegovy semaglutide. So you can see, in order to get or reach the maintenance dose, it can go up to 5 months or 17 weeks. So you have to slowly start from 0.25 mg each week for 1 month. Then second month you increase the dose to 0.5 mg. Then third month 1 mg until you reach the 2.4 mg maintenance dose. And then you have to stay on this dose until you reach your desired weight loss goal, the target goal. Then question is, do we have to take it throughout our life? When we should stop it? So as per the clinical trials, it has shown that it is okay to take this drug for 1 year up to 2 years. Then it is on the patient that when they are ready to stop it and they have already trained themselves on the lifestyle modification. Because once you stop taking this drug and you come back on your old sedentary lifestyle, you do not control your diet, you do not go for exercise, the weight will bounce back. So it is not a permanent solution. You must change your lifestyle modification as well. And in terms of cost effectiveness, some of the studies shows that bariatric surgery gives you cost effectiveness option. Of course, in the beginning, when you are giving lump sum amount for that surgical intervention, it looks like it is very expensive. But when you are using this drug up to 1 year, 2 year and above, it can be more costly as compared to the bariatric surgery. And this is not a permanent solution. So now question is, how do we choose between surgical intervention versus this simple injection technique? So this comes to patient intervention, patient preference. Some patients have fear of surgical intervention. They are scared of the surgery, that letting their part of the body, part of the stomach to be removed. They have very fear. And some patients, they have fear of injection. They don't want to go for the injections. Then they may also go for the oral dosage form of the GLP-1 agonist. Okay, here we can see the comparison that how Wegovy and Mounjaro are effective in reducing the weight. So Mounjaro, because of its dual mechanism of action, so you can see that it has shown to be more superior as compared to Wegovy. Okay, so this is on the oral semaglutide, which is Rybelsus. So it also has to be proven to reduce the major adverse cardiovascular event, as well as it will reduce your weight. So those patients who are more comfortable in taking the oral dosage form, they can try the Rybelsus as well. Okay, so this is something which is undergoing clinical trials. We have oral semaglutide 25 mg, high dose of semaglutide, oral dosage form, and a new drug which is orforgliprophan. So this is also under clinical trials. These drugs have not been approved by FDA yet. So under these phase 2 and phase 3 trials, these drug has shown promising effect, like oral semaglutide 20 mg achieved more than 13% of the average weight loss as compared to the previous 14 mg semaglutide. And this orforglipron 36 mg, it has shown 11% higher weight loss as compared to the other drugs. So these results suggest that oral therapy may soon match the injectable drugs like your Wegovy, and patients will have more choice and more confidence that do they want to go for injectable form or oral dosage form. But as of now, of course, the injectable dosage form will win in terms of effectiveness, or you can say the potency. Currently, the oral dosage form is not as potent as compared to the injectables. But maybe in future, as per these clinical trials, the oral may be equivalent to the injectables. Okay, so until now, we have just talked about the benefits of these drugs. But of course, every drug have their ADRs, have their side effects. And so what are the safety concern and expected side effects from these drugs? So one of the common side effects which has been frequently reported for Ozempic is stomach paralysis and vision loss. Okay, so how Ozempic is causing blindness? It is multifactorial. It is because of the changing blood sugar levels, can be due to medication interactions, or diabetic retinopathy itself, that the blood glucose level is so high that it is causing the diabetic retinopathy. Can be due to allergic reaction or hypoglycemia. So we cannot simply put blame on Ozempic. It is multifactorial. It can be due to uncontrolled sugar level itself also. So this non-arteritic anterior ischemic optic neuropathy, which is also called NION, so it can cause vision loss also, but this is not that prevalent. And by what mechanism this Ozempic can cause gastroparesis? Because when patient is always, feeling longer that they don't have appetite, they will always feel full. It curbs the glucagon excretion also, and also it slows the stomach emptying time, which can lead to gastroparesis. When patient will have, long time slowing of the gastric emptying time, so the muscles, they can lead to gastroparesis. But how much frequent it is based on individual to individual. But as a result of this mechanism, the symptoms which the patient might be experiencing is nausea, vomiting, abdominal bloating, pain, acid reflux, heartburn, and also their frequency will differ from one patient to another patient. So here is a very nice comparison of your normal insulin like Lentus, what are their GI related side effects versus Ozempic low dose 0.5 to 1 mg, which is the higher dose. So the most frequently reported side effects by the patients are nausea, diarrhea, and vomiting. And another complaint which the patient reports is when they are taking Ozempic or Wegovy, they are not able to digest meat or heavy appetite. Whenever they try to eat lamb or beef, which is difficult to digest, they tend to vomit it. So also patient has to adjust their dietary habits when they are taking Ozempic. Like they have to take some soft diet, which is easy to digest. Of course, all these side effects, their frequency, it will vary from one patient to another patient. Another controversy regarding GLP-1 agonist was previously due to some case reports that it may cause pancreatitis or it may increase the risk of pancreatitis. So here we have seen that the recent studies have shown that there is no direct link of pancreatitis risk with the use of GLP agonists. Those patients who were not taking GLP agonists, they have shown more risk of pancreatitis. So this causal association was ruled out after this recent study was published. Okay, so take home notes is that personalized approaches in clinical practice is the moving forward. So how we choose the drug, it is based on the patient stratification, based on their BMI. If they are obese, go for GLP. If they are having heart failure or cardiovascular risk factors, then go for SGLT2 inhibitors. But lifestyle modifications, diet, exercise, behavioral intervention, they must be incorporated with the pharmacotherapy plan. And the next important thing is monitoring. If we are not monitoring, then how we will know that patient has achieved the glycemic control or not? So the digital health and AI and also the continuous glucose, blood glucose monitoring, that comes into the loop. So studies have shown the technology's role, the continuous glucose monitoring, it provides a better and strict control of the blood sugar glucose, and patients are more, you can say, involved in their therapy. So these are all the technological options. Patient can get the real-time data on their mobile phones, and if there is any deviation in their blood glucose level, and if there is a need to adjust the doses, so they can always go back to the pharmacist and their doctors, and the adjustment in the diet or in the medication plan can be made. Okay, so the conclusion is pharmacological advances have transformed the diabetes management from glycemic centric to the patient centric now. And personalized medicine offers promise for optimized and patient specific outcomes. So we have to see the patient comorbidities while we are choosing the best anti-diabetic for them. And integration of these digital tools and AI, they can also shape the future of diabetic care in a better way. Okay, that's all for my talk today. Thank you so much.
Okay. Thank you so much, Dr. Junaid, for your clear and informative presentation. It's inspiring to learn how the right medication and care strategies can improve patients' daily lives. Now, we will open a discussion. Please share your question through the chat box, or you can raise your virtual hands, and let's make the discussion lively and meaningful. For our audience, we have a little surprise. There will be a door prize for 4 lucky participants who asked questions during the discussion. Each winner will receive a GoPay voucher worth 50,000 rupiah. So don't be shy, send your question and you might be one of the winners. All right. We have received several interesting questions from our participants in the chat box. Let's take a few of them and hear the responses directly from our speaker. Anyone wants to share screen? Okay, first question is for Mr. Maula Ismail Muhammad. And the question is, since your study used secondary data from SKI survey, how did you ensure that data validity and consistency, especially considering the self-reported nature of diabetes diagnosis, and how might this limitation affect the interpretation of the clustering result? And this question comes from Mr. Hilmi Ila Robibi, a lecturer from Dental and Oral Health Therapy of Poltekkes Kemenkes Tasikmalaya. Mr. Maula, would you like to respond to this one?
Yes, thank you. Thank you very much, Mr. Hilmi. What is the question? Okay. How did I ensure the data validity and consistency, especially considering the self-reported nature of diabetes, right? And how might this limitation in the interpretation of the clustering result? Okay. Indeed, this study used secondary data from SKI 2023. It is nationally representative data set collected by Ministry of Health. For the SKI itself, I believe that the data is valid and reliable, but maybe for my research purpose, I'm controlling it with framework. It's called knowledge discovery in database or KDD framework for data mining. Each steps including many steps preprocessing data. We transform all category data into 1 and 0 data. So the data is numerically consistent throughout analysis. Later, according outlier and else, we using a step called scaling the data. So it's effectively mitigate the influence of extremely value, because all the data is now on a standardized format. So the K-mean that use Euclidean distance, he the algorithm is what it's called, he measure the centroid from its data. It's more good for the K-mean algorithm. Of course, interpretation, we have to be careful. in my research, I also state that data, that source of that Y variable, the diabetic variable, I state that it came from self-reporting. So we know as a researchers, it may be recall bias and etc. I think it's from me like that, from my controlling from the question.
Siap-siap, aku lagi. Okay, thank you, Mr. Mola. And I hope it's clear, Mr. Hilmi. I see that we have one of our participants that raising their hand. That's great. Miss Wardatul Jannah. You can please go ahead and share your question directly.
Okay, thank you very much for the opportunity. So first of all, I would like to say thank you to our speaker today who give insight, too many insight, and then this is good for us to improve our knowledge, and especially me as a pharmacist in Indonesia. So I am a doctoral student from University Pajajaran University, and then this is so attractive to me. Our second speaker talking about diabetes mellitus in his country. So my question is for our second speaker. If I'm not wrong, our second speaker is Dr. Junaid. This is right?
Yes, please. What's your question?
Okay, thank you, Dr. Junaid. So maybe my question is not related directly about the medication. I mean, like not about the traffic, but in other hand, I would like to ask you about the trend in your country about how you measure the medication adherence from patient with diabetes mellitus, because now in my research I specially develop the one of method that can measure medication adherence, but this is new in Indonesia. I mean, before we use subjective data like self-report to measure medication adherence, but now I try to develop one of method to measure medication adherence, and its name based on dispensing database. So I want to know, in your country, how about trend about this method? I mean, maybe it could be good insight for me, because this is
Share aja
so
sama
related
siapa
with
aja.
my research now, and maybe you can explain about the trend and one of the best method to measure medication adherence, especially in patient with chronic condition like diabetes mellitus. Thank you.
Okay, thank you, Ms. Wardatul Jannah, for your question. So it's good to know that you are working on adherence and you have developed some new methods. So maybe after I answer you, You also share that what is the new method which you have developed so everyone can get benefit. Okay, so to answer your question, there is no single method to assess medication adherence because the reason of non-adherence will be different from one patient to another patient. Okay, like for example, the causes of non-adherence, it can be intentional versus non-intentional. So we have to assess, first we have to figure out that why the patient is non-adherent. Then let's suppose if it is due to forgetfulness issue, patient has busy lifestyle or such kind of issues are there, then we can give them those medication reminders or pill boxes, or now we have all these reminders on mobile phone applications like that. And if, let's suppose, patient is non-adherent due to their mindset, they don't believe in medications, they rely on complementary medications like that, then we have to educate the patient first. Let them know the importance of taking the medication only. Otherwise, no matter how much you put efforts, if patient is not convinced, they will not going to take your medications. And in order to assess their non-adherence, especially for chronic conditions, so like for example in diabetes, the most easiest method is when patient comes, you check their sign and symptoms. Are they under control or not? Check their HbA1c. The HbA1c will give you idea for the past 3 months. Then you check the medication possession ratio, which is how frequently patient is coming for medication refill. How long is the interval? Is patient skipping the doses or not? Because like you mentioned, the patient administered questionnaire, they might not be so reliable. Patient can lie in front of, yes, I'm taking medication, but in reality, they are not taking the medication. So we have to use subjective methods and objective methods together with the clinical analysis, evaluation of the patient sign and symptoms. And then you can advise them based on the loophole, the gap, that why your patient is not taking the medicine. Sometimes it can be due to the cost effectiveness issue. Patient do not have enough money to buy all these things. So then you tailor make the approach for the patient and set a individualized plan for that. Just like a pharmacotherapy, so adherence is also a individualized plan. Yeah, I hope I have answered your question.
All right. Well, we still have a few questions in the chat.
So shall I start answering that? I can see one question there.
Yeah.
So
it's from
here it
Aldi.
says, yeah, the question is about practical implementation of personalized medicine in countries with limited access to CGM, continuous glucose monitoring, and AI-based tools. How can personalized approaches be realistically applied in diabetes management? Okay, very good question, because we all know that CGM monitors, they are quite expensive, and it is not so common in our society. Only maybe in clinical trials or in Western countries where people can afford these things are there. So what about a normal patient, a common man? So we always go back to our conventional methods. So what is our conventional methods? We need to maintain patient diaries. Okay. So in that patient diaries, whatever patient is taking the diet, so they will keep on writing and maintaining those diaries. And if we want to make it a bit modern, because now these days everyone has mobile phones with them, and we have free Android and iOS applications to keep track of your dietary patterns, that what you are eating, what are the calories. Very simple tools are available there. So whenever patient is going for follow-up, or let's suppose patient is using those finger prick test to measure the fasting blood sugar or random blood sugar. So if there is any deviation in those values, so patient has to write down and note it down, either in their mobile phones or either in a simple manual patient diaries. And then here the question is not only why the patient has spike. So we need to evaluate that what is the underlying cause. If let's suppose after 4 or 5 days or after 1 week, there are few spikes being observed. So the healthcare professional or the pharmacist should discuss with the patient that what has happened. Is there any change in the dietary patterns or patient forgot to take the medication. So in this way, when patient has complete record, then we can still manage this patient condition without going for all these AI and the CGM monitoring tools. And secondly, CGM is mostly useful for patients on insulin. Type 2 diabetes patients who are on oral hypoglycemic agents, CGM is not really beneficial for them because there is no, you can say, sudden fluctuations in their blood glucose levels for type 2 patients.
All right. I think there is one more question from Ms. Eliati, a lecturer from Dental Nursing Department. He asked about the mechanism by which diabetes can cause tooth mobility and what are the prevention measures. You may answer this.
Mechanism by which diabetes can cause tooth mobility or tooth decay.
Ms. Eliati, would you like to confirm?
Yeah, so this is the same thing that
Yeah.
in diabetes patient when they start losing their teeth. So again, the main core of this is strict glycemic control. So if the glycemic control is strict, patient glucose level is not that high, so we can reduce this thing. And those patients who are at the risk of developing this, strict or you can say more oral hygiene should be preferred in those kinds of patients. Like you have to brush your teeth, use Listerine mouthwash. So the more better or healthier the gums are, the incidence of this tooth decay or tooth fall can be minimized.
Okay. Thank you.
You're welcome.
All right, I think it's clear. So thank you everyone for your great question and also active participation. And of course, our gratitude to both of our wonderful speakers for sharing such a valuable insight today. And to express our appreciation, we will now have the certificate of appreciation ceremony for our two invited speakers. The certificate will be presented by Vice Director 1 of Health Polytechnic, Ministry of Health, Tasikmalaya. We kindly invite Vice Director 1, Dr. Asep Kuswandi, Bachelor of Nursing, Nurse, Magister of Nursing, and Specialist in Surgical Medical Nursing to present the certificates to Mr. Maula Ismail Muhammad, Bachelor of Engineering, Magister of Public Health first.
Okay, thank you, Miss Kanita. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Distinguished speaker, respected participant, and honorable guests, good morning and warm greetings from Poltekkes Kemenkes Tasikmalaya, Indonesia. And on behalf of Poltekkes Kemenkes Tasikmalaya, I'm honored to present this certificate of appreciation to Maula Ismail Muhammad ST MKM from Poltekkes Kemenkes Tasikmalaya as invited speaker 1 for the plenary speech 1 entitled Harnessing Big Data and Digital Health Analytic to Understand and Improve Life Satisfaction in Diabetes with Chronic Complication at ICHET 2025. Thank you for your valuable contribution and please accept this certificate as sign, dedication, and appreciation for your effort in knowledge sharing.
All right, thank you. Now, for the next one, I would like to present the certificate to Dr. Muhammad Junaid Farouk.
All right. And then on behalf of Poltekkes Kemenkes Tasikmalaya, I am honored to present this certificate of appreciation to Professor Dr. Muhammad Junaid Farouk from UCSI University, Malaysia, as invited speaker 2 for the plenary speech 2 entitled pharmacological intervention for chronic diabetes complication, improving outcome and life satisfaction at ICHET to 2025. Thank you for your valuable, and we hope we can meet again, Mr. in Indonesia. Yeah, we have follow your country, and it is very warm, very nice in Malaysia. And please accept this certificate as a sign dedication and appreciation for your effort in knowledge sharing.
Thank you, Prof. Asif, for your kind invitation to invite me and share this talk. And yes, I hope to meet you next time in Indonesia
Amin. My pleasure.
and see you again in Malaysia next time.
Yeah, see you, Mr.
Thank you so much.
All right, thank you, Mr. Asep, and congratulations to our speakers. Let's give them a big virtual applause. Now, we will continue to plenary session 2, featuring 2 inspiring speakers who will share about public health strategies and how to empower patients in managing diabetes complications. Our third speaker is Dr. Zong Manuel Correa Jimenez. Before we start, I would like to start with a simple thought. There is saying that preventing is always better than curing. But how can countries, especially developing ones, strengthen prevention for diabetes complication? And to answer that, we have Dr. Zong Manuel Correa, Magister of Public Health from Universidad de Dili, Timor-Leste. Am I spelling it right, Dr. Zong? I would like to read his CV first. All right. As we can see in the screen, Dr. Zong is a medical doctor and lecturer who has taught subjects such as anatomy, physiology, and professional ethics. He also works with the Ministry of Health of Timor-Leste and focusing on programs related to non-communicable disease and elderly health. Well, let's warmly welcome Dr. Zong to share his insight. How are you, Dr. Zong?
Hello, good morning to all.
Good morning.
Everyone. I hope you can hear me.
Yeah, it's clear.
I'm
You can
fine,
start
thank you.
your presentation.
Okay, because of the technical issue, I think my slide will be shared from the part. Thank you for this. First of all, I would like to thank Poltekkes Tasikmalaya. This is the second time for me personally and for the University de Dili to join seminar, international seminar, to share something related to our country, Timor-Leste, especially in the public health policy to handle, to tackle the health issue in our country. So thank you for that. And I very happy because just two previous speaker already talked and share very beautiful and insightful information about the clinical parts and also the research related to the diabetes issue in Indonesia and also Singapore, maybe Malaysia. So, sorry, the Dr. Junaidi and the other speaker. So I would focus on the clinical part. Of course, I will go directly to the public health policy, especially the country like Timor-Leste, low middle income country, Timor-Leste, to tackle to overcome the issue of the diabetes. Thank you so much. This next few minutes ahead, I will bring you come to our country to know something about the diabetes in Timor-Leste and how we tackle this issue. Next slide, please. Oh, hello. Next slide. Yeah. So why it matters? We already heard from the Dr. Junaid, uh, uh, the clinical issue about the diabetes complication. So it's become the more important for us to care because it's really burden us. We know that from time to time, the situation, the condition related to diabetes to decrease, but it's increased. So instead of all the technology, all the advanced knowledge, the situation is getting worse. This is something that we need to focus on that. It become the public health burdens worldwide, not only in our country, in Timor-Leste, but it's worldwide problem. So especially the country like us in Timor-Leste, we need to look through this situation because every 13 seconds, somewhere in the world, someone can lose their lower limb. The situation increased 10 times for the kidney failure. And maybe one of us here, 1 in 3, some in us that also participate in this meeting, they have a risk to get the vision loss and also 3 times the risk for the cardiovascular disease. That's why we need to really care to this situation, and we need to bind together to help country, to help people who really face this situation, struggle for this situation. So what is beautiful is that with the proper care, diet, physical activities, proper medication, and monitoring, all the complications, some of the complications can be delayed. So we're waiting for the very good intervention in the next some years ahead, or the complication can be prevented. So that's why all of us, we are called to really care about the situation. So here, I would like to bring you to ask all of us here to focus on the early detection, proper management, and lifestyle intervention uh, can really help us to tackle this issue. Next slide, please. So as we see the data here, reached to 81% with adult with the diabetes live in the country like Timor-Leste. So we really struggle for this situation. We really need help from brothers in Asia. Just 2 days ago, 2 or 3 days ago, Timor-Leste became the new member of Asian country. So this is good opportunity for us to get some more help from our brothers from Indonesia, from Malaysia, from Philippines, and so on. So to tackle the diabetes issue in our country. So by 2024, the data report more than trillion US dollars spent to overcome this issue. It's a lot of money, especially for us here. For Leste, it's a lot of money. So that makes sense that it's a diabetic problem, and with the complication, it's really a public health problem, public health problem for all of us here. So like in the middle income country, so the major tribes that can affect this situation can happen, something like urbanization, aging population, and physical inactivities, and some recently in Timor-Leste also some people get overweight condition and obesity. because of life-changing, lifestyle changing that suddenly happened to us in Timor-Leste. Before we are, it's simple people, but then after we have our restoration independence in 2002, and just 5 years back, life-changing become happening in Timor-Leste because people start to consume, to access young parts and things like that, and uh, access to the alcohol and also the it's the higher than years before. Next. So I will not focus on this, but of course, just a reminder for the participants, it's a chronic situation about the metabolics and that's happening in our body. So related to the, it's a metabolic disease. So something that is very linked to our lifestyle, especially in the diabetes type 2. So next slide. Next slide. Yeah. So the key elements in the definition that we can take is the diabetes is chronic and metabolic. This is elevated blood sugar, and then sometimes it's insulin dependent for diabetes type 1 lead to the serious damage. Dr. Junaid already show us what the worst complication of this situation, this condition. But we have to focus on this issue so we can tackle, we can overcome. So it's a required management, prevention of the complication. So we emphasize on the early detection, treatment, and also risk factor control. Next. As we know, there's four types of diabetes already explained by the expert. I think we just go through this slide. Next. And also the cardinal signs of the symptoms, signs of the diabetes is like polyuria, polyphagy, and also tingling and pain in hands or something like that. That Dr. Junaid already explained in previous presentation. What is important is mainly for the diabetes type 2. It's often undiagnosed, it's often unaware, and once we know that it's already developed, even slowly, but it's already developed to the complication. So once we diagnose or detect it, it's like it's already late. That's why the public from the primary health care, we need to focus on that. This is the complication of the diabetes, micro and macrovascular. That's already explained from the Dr. Junaid. I think we go through this slide also. Next slide. So transition to Timor-Leste. Why we have to look to Timor-Leste? It may be a good example for the lower country like Timor-Leste. Maybe with this presentation, all the participants, especially all the experts here, will have a good idea because you know that a country like us really struggle on the handle to overcome the situation. So the presentation will include the prevalence and burdens of diabetes in Timor-Leste, the SWOT analysis of Timor-Leste on diabetes, and the policy that we settle to overcome this issue. Next. Next slide. Okay, the prevalence, the actual data that we have is age standardized prevalence adult year 20 to 27 years old. In 2024, it's 3.2%. Maybe country like Indonesia that has a very big population, this 3.2 is something that maybe not very important, but we in Timor-Leste, we just 1.3 million people here, so this number is very, very important for us to look at. So recent data show that 21,000, 21.6 thousand adults affected by the diabetes. And I'm in the primary healthcare clinic as a medical doctor. Every day I face the patients that mainly women that have problem with the diabetes issue. So in our data also show that 4% people with the raised fasting blood glucose level in adult, and we compare with the 2011, it's increased 7.5%. So in Timor-Leste, the facts show that women dead because of the diabetic and its complication, it's 4 times rather than men. Next slide. So it really has a significant burdens for our health system. It's become very hard for us because of some factors that we has in Timor-Leste, we have in Timor-Leste, like the access challenge. As we know that Timor-Leste, it's a developed country, with a low middle income country. So people, it's only 30% people concentrating in the urban area, but up to 70% people they stay in the rural area. So it's make a very big challenge for us to tackle the issue. And another thing is a lifestyle, our cultural and also our belief. It's really really hard for us when we talk about the diabetic, how we can handle the situation, because every time we always have the like party, something like that. It's a traditional cultural activities. It's involved consuming the sugar, a lot of sugar, and also the lipid like meat, something like that. So it's really hard for us. It's really aspect that we need to struggle to overcome it. And also about our health system, the limited resource in health workforces, infrastructures, and also the equipment that we use to tackle the diabetic disease. It's also a problem for us, and it leads to the late diagnosis of the diabetes in our country, and that makes us to delay on our treatment for the diabetes. So the initiative we already plan to do in Timor-Leste. For example, we have a goal to reduce to 50% of the diabetic disease, people with the diabetic disease, to 50% by 2025. By the bring in each health facilities to bring at least 50,000 people for the hypertension and or diabetes screening by the end of 2025. And what we do is we integrated all the program to the NCDs, We settle this in the primary healthcare level, and we try to influence our community to intervene their lifestyle, daily lifestyle. Thank you. Next. So this is the short analysis about our situation in Timor-Leste, how it shows how really hard for us to uh, overcome the diabetes issue in our country. So we have a government. It's good that government have initiative, commitment to handle this issue by the provide grant protocol. It's integrate the package for the intervention for the non-communicable disease and the real implementation we put in the piece for the integrated Saudi. So it's like maybe in Indonesia, something that we call the posyandu, that we bring the health services to the community, among the community. And we start this from like 2012, something like that. So, and another thing is our strength because we engage the community leader in all the health program. So the community outreach, it's led not only by the health professional, but also the community leader in that area. So this is something that's good for us. The weakness is we have very limited health workforce, the capacity in terms of capacity and the number, especially the medical doctor that specialize in the diabetic or internist, very limited in Timor-Leste. The other thing, like you already mentioned, that it's a rural and remote area because people live concentrate there. They don't want to go out from their village, their culture. So they stick. They want to stay there, even it's far from the health facilities. It's far from the health access, but they stay there. That it makes very hard for us to reach them. The opportunity is with the support of the NGOs, mainly from the WHO, we initiate innovative approach like open gym that we put in every center, every corner in the each city. We start in Delhi or mainly in each municipality, in the 30 municipality, almost in every country, at least 4 to 10 corner. We put the open gym for people to exercise. They can use that for exercise. And especially in Delhi, maybe once in three months, we do the walk the talk. So with the support from the WHO, Ministry of Health, normally conduct activities we call walk the talk for 2 or 3 hours in Delhi, something like that. And then we have the achievement to do community screening for the early detection that support from the some countries and also from some NGOs. So this is a big good opportunity for us to handle, to overcome the diabetic issue in Timor-Leste. And again, the treat is our lifestyle, our cultural belief, our cultural system, and our belief system. It remains a very hard issue that we need to concentrate there alongside with the urbanization circumstances. So another thing is we Timor-Leste until now we dependent to the another country, so especially for the medication all the health supply equipment, and sometimes the healthcare provider is still depend to the other country. For the medical doctor, we still depend on the Cuban doctor. Uh, Sometimes the general practitioner also, we depend on them, but mainly for the specialists in each area, including the internist. We depend to the Cuban and Chinese doctor here. And another thing is the trick is about the gender inequality in Timor-Leste. Until now, even it's already reduced, but still exists the gender inequality in Timor-Leste. Next. So next slide, please. So we focus on the, hello, next. So we here, we need your help to focus on the public health strategy to help us to overcome this the diabetes in Timor-Leste. So by the preventing complication, it's more because cost effectiveness than managing advanced disease, because sometimes we run out of our education equipment and also our infrastructure that cannot very properly to handle the situation. So the prevention and the early detection, it's very important for us to work on that. So for Timor-Leste, with the limited resource, early detection and prevention, it's become the first option for us to prevent the complication or to decrease the mortality to the diabetes disease. Next slide. So this is a comparison. So we like globally the prevalence of the diabetes is also high in Timor-Leste, almost 4%. And then globally, the NCD agenda with the WHO guideline become the major focus policy. So, and also in Timor-Leste, call it the PEN, and the initiative for the 5THINTERNATIONal initiative. We start piloting in Dili and Haile municipalities, and also the integrated outreach program we call the PEACE. We focus on that policy. So the key challenge that we already talk about is about the workforce, remote access, supply chains, lifestyle, and our economic financial capacity. Next. So based on that, we elaborate our policy strategy to three main policy. The first one is the community-based screening and prevention program. So we conduct outreach to the rural area. We prioritize the people who are most vulnerable, the risk, and also we promote the healthy lifestyle to change our lifestyle that exists for years. We take it from our ancestors, and we also track and manage the patient data so we can follow up the patient that we already catch and we put on the program to intervene in clinical area. So next slide. Next, please. Yeah. So what we consider to implement this is that the unscreened population outreach also become a problem because our limited resource. So the mobilization for the resource also become a problem linked to the geographic situation and also because of the limited health workforce. And we try to apply the very simple tool for the to catch the people with the diabetic problem, like blood sugar, simple rapid test for the blood sugar, uh, so fasting and also the other one. So we do this in the health facility. Sometimes we with this program we go to through its house. We meet the people who are already 30 years above. We conduct the rapid test for them. And if there is a positive cases, to put them in the program, trend program, to start the intervention on the medication. And sometimes we need to refer them to the higher level of the health facilities because sometimes in the primary health facilities we don't have the adequate medication and also the equipment to support to help them. And the monitoring evaluation to cover all the to track it to cover all the activities that we already done to our community. It's also our concern. We try to develop the best way, the best system that can track our activities appropriately. Sometimes we, because of internet issue, some data we just lost some data or we cannot input or provide the proper data to our activity related to our activities. Next, the second strategy, previous slide. The second public health strategy, previous slide, please. Sorry. It's the previous one. Just one slide. Yeah. No. About one slide before. Yes. The second health strategy is health promotion, education campaign, and access for the equity. So this has become the more important main activities that we do in our country. We learned from the Sri Lanka 5 years ago that like in Indonesia, post-linggo, pustu, something like that. Here we call the health post, and sometimes the center of the treatment. So we work in the morning, but in the afternoon, health of course we mobilize them to the community to fetch the community who are stay in their house. They don't want to come to access the health facility for at least for check their health condition. So we go there every day, and then we conduct the health promotion and also health education, and sometimes we conduct the rapid assessment for them, and sometimes also we start the treatment in their place. So the health promotion, health campaign, it's not only happen in the health facilities, but sometimes in the group, specific group of people, like in the uh, schools, in the village, in the uh, religion activities, in sport activities, and the art activities. We also conduct health promotion related to many situation and condition, health condition, especially the NCDs, disease that relate to the NCDs, mainly now hypertension and diabetes. Next. Key messages for these activities, the health promotion, is that we need to focus on the person. We encourage each person to. We say to them that your health is your business, your health is your hand. So please care about yourself. This sentence is clearly articulated in our constitution that our health is in our hands. So we are asked, we are called to be responsible for our own health. Even the government, the country provide something for us to help us, but first of us, we are the one who take responsibility for ourselves. So with the activities, health promotion activity and campaign, we expect that we can reduce the risk of the factor that lead to the non communicable disease, especially diabetic and also hypertension. So, as I said before, that the cultural activities here is so intense. So people start from the very young age already access to the tobacco, caffeine, and they are some of them very for the day weight. So we hope that with the proper health promotion and education, we can increase that risk factor. And by this activities also we promote, we expose to our community the concept of healthy lifestyle. So how to manage their own style, especially in the consuming what they consume every day, so they can prevent themselves to fall into the non-communicable disease like diabetes. And next. The third health strategy, public health strategy, is in the policy level intervention to reduce long-term diabetes burden. So here, so we set some policy to fix the situation that we face in our country. So start from the fiscal measures. We increase the taxes for the sugar drinks and junk food, something like that. And then we start to make the proper food labeling, because we can say that 95 to 98% what we consume, what we use in Timor-Leste, is import from abroad. So it's really hard for us to struggle on this. That sometimes we cannot access what they produce, the concentrations, and that they put on the food that they import. We already have some example that some people try to bring poison to us, to Timor-Leste, and we are happy because even with the very limited resource, very limited capacity, our government through the like Indonesia Balai Pom, here we call the IPAESA, they already give some important important assistance on that issue. And along this strategy also, we strengthen the health system. So ensuring access to the medicine, diagnosis, we train health workforce properly on the relevant issue. And in the primary healthcare level, we conduct the integration intervention, integrated intervention for the disease or the situation that happen in our uh, our country. And all of this we adapt to the WHO approach by the through the brain and also heart program. So, and also the last thing is the monitoring and surveillance system. We establish this with the support from the WHO and also the NGOs. They help us to establish the good mechanism for the monitoring and evaluation to prepare or to provide very good surveillance data related to the disease in Timor-Leste, including the diabetes. Next. So this is like the hierarchy of the policy. That we focus on the our environment, our community. So we enable them to participate actively in the process to tackle to overcome the diabetic issue. And we focus on the primary intervention, like health promotion and the lifestyle change, changing in lifestyle. And then secondary prevention, we conduct the screening and the early diagnosis to prevent the early detection and to prevent the complications from the diabetic disease. And tertiary prevention, we manage to conduct the manage the complication that already happened, and in our policy we put this in the system so we can monitor and evaluate. And lastly, now we are using the technology and media to share the information and also now to train our health workforce through the media, something like that we are now doing. Next. So the initiative that Timor-Leste already taken to overcome the diabetic problem in Timor-Leste, as I said before, start with the open gym program, walk the talk program. We engage the community leader in all our activities because they are the who stay closely to the community. And the WHO program, HEART program, we adapt it to the Timor-Leste HEART. We expect that with the local context approachment, we will get the better result. The national target to bring 50,000 people in each health facilities by the end of 2025. We start from early 2024. So we expected by the end of this year, we will have in each facility at least reach to the 50,000 people with the screen for the diabetic and also hypertension. We use the mobile health facilities for the screening and also for the follow-up. In our system, we call the PSF, Pessoal Saudi Familia. One person in each, in Indonesia we call dusun, here we call aldea, one person in each aldea, to look after their own people who have problem with the NCDs, disease, something like that. And we collaborate with the NGOs, international and national, to support our activities, and integrated diabetes prevention with the uh, WHO, and also from Australian and also American government that they listen to Timor-Leste. Policy advocacy on the food, environment, physical activities, infrastructure, taxation for the unhealthy product. Okay, now we focus on that also. Next slide. So in Timor-Leste, this problem remains our challenge because what you already said that it's a geographic issue. There's a gap on the human resource for the health workforces, number and also the capacity. We struggle for the supply chains issue and low awareness of our community. We are also struggle for the and mainly also we are struggle for the data limitation. There's not many research or many activities related to the NCDs program, especially in diabetes and hypertension. So we, as a national, we really have a very limited data on the diabetic situation. Next. So comprehensive diabetic monitoring in Timor-Leste, we completed with the screening coverage. Number of people screened by the in the rural and also urban area. So through the health facilities and this program, and we found the newly diagnosed case. We intervene directly. If there is there is a limitation on the some facilities, then we will refer to the higher facilities that have the proper resources. And the treatment protocol we adapt to the WHO. I think today I'm very happy because I can hear from the expert, Junaid, about diabetes. I hope in this seminar also we have the dean of the health and science faculty with the people here. Maybe we can arrange something with the Dili University Dili with the Poltekkes Tasikmalaya. So maybe next time we can conduct the same activities not in the Tasikmalaya but maybe in Dili Timor-Leste. I hope that we can make this happen in soon. The complication incidents also become a problem for us to track because we are not used to report everything. Even in the policy, one of our indicators we put there as our indicator is the report of death because of the NCD disease. But until now, like in the place, none of our community report to us when they lost their family member. But there is no data, specific data to health facilities or health system. We don't know what actually the main cause for their deaths. And mortality rate is still high related to the diabetes. It's because of our limitation on the intervention process and also our limitation on the early diagnosis process. So sometimes we run out metformin, the very basic medication for the diabetic intervention. So when I hear that Dr. Junaid talk about the advanced medication, I think that maybe Timor-Leste will talk about it in the next 2 or 3 years ahead. Today we are still struggling for the primary medication to intervene the diabetic, like metformin, and something like that. So the last one is the equity measure. So we analyze of diabetes impact across the different social activities. Next. I think this is the last of my slides. So we emphasize again the point, why we need to focus on we need to care to the diabetic issue because it's a global burden. We say that more than $1 trillion US dollars spent in 1 year just to overcome this issue. So it's a lot of money for the countries like Timor-Leste, Indonesia, and also Malaysia, but mainly for countries like us, it's a lot of money. So in this presentation, of course, we are focused to the Timor-Leste situation, and we share to you the importance of public health strategy and reduce the complication of Leste. So another things we emphasize, shift from the reactive to the proactive care. So we are not sit here, but we face the situation. We come to the community proactively, so we can do the early diagnosis and early treatment for them, so we can prevent the complication, or we can delay the complication the diabetes problem. So call for action for public health students or future professionals. It remains our focus and our goal. So we believe that new generation, they will do something better compared to the existing generation. So now Gen Z, something like that. We hope that the new generation of Timor-Leste also they attract to this situation. They are aware and they willing to prepare themselves to tackle the diabetes. I think this is my final presentation. Thank you so much. Again, I hope that this will bring you something that insightful about our country related to the diabetes issue. Thank you so much. Otherwise, aku
All right. Thank you, Dr. Zhou, for that enlightenment talk. It reminds us that small changes at the community level can bring big impact to public health. And before we move to Q&A session, we still have one more speaker. Our next speaker will bring us closer to the human side of healthcare, because beyond technology and medicine, it's empowerment that helping patients believe that they can take control of their health that truly makes a difference. So last but not least, please welcome Miss Anjanette S. De Leon, Master of Art in Nursing, registered nurse from the Philippines.
Hello, good afternoon, everyone. Can
Good
somebody share my
afternoon.
slide, please?
Yes. Wait, I will read your
Yeah.
CV first.
Yeah, go ahead. Go ahead.
Okay. As we see on the screen, Miss Anjanette is a nurse educator with more than 20 years of experience in teaching and clinical practice. Wow. She teaches at Centro Escolar University Manila, and is a board member of the Philippine Association of Diabetes Care and Education Specialists. She has trained hundreds of health professionals and developed diabetes self-management program to help patients to live better lives. And today, Ms. Anjanette will present about empowering patients to manage chronic complications and enhance life satisfaction. So the floor is yours, Ms. Anjanette, and for the operator, help me to share the screen.
Thank you for the generous introduction. Can somebody share my screen, please? The slide, please. Okay, thank you. It is always better to be the last speaker of a conference, right? Because I will be just summarizing all the brilliant discussion of our speakers today. I think everything was discussed already. However, I will just like to highlight some important information and updates. Okay, so my talk today is about chronic complication and their impact on life satisfaction in diabetes and empowering patient to manage chronic complication. Next slide, please. Let's move on to the global burden. I think the global burden of disease about diabetes, from the very start of the conference, they've been discussing about the global burden. On the fourth slide, please. Thank you. All right. That's it. Okay. So I will be just highlighting here that in 2050, it is projected to increase up to 850 million. And what is concerning here is 81% of adults with diabetes live in low middle income country. And what really a challenge for Indonesia is that from the data of Diabetes Atlas in 2025, that the Western Pacific region has the third highest prevalence of diabetes, which is 12.4% in the world. And there is, aside from China, no, Indonesia also ranked as top 5 countries in Western Pacific region with 20.4 million in 2024 and projected to rise to 28.6 million in 2050. That's why I am listening to the talk of Dr. Jimenez a while ago when she presenting in the Ministry of Health, no, how to overcome all of this, and a challenge really to the Ministry of Health because Indonesia is ranked third, 73.2% proportion with undiagnosed with diabetes and 15 million of people undiagnosed still with diabetes. So this is a challenge, no, to Indonesia, and I am really happy that in this conference you are talking about diabetes. Next slide, please. Okay, on this slide, no, some of our speakers a while ago also talk about the complications of diabetes. The major epidemiological data on CKD comes from high-income countries. But how about those lower socioeconomic status? They experience the largest increase in diabetes prevalence, and their population with diabetes are more higher at risk with CKD. Just like what the World Health Organization is telling us, no, it is caused over 2 million deaths of CKD. Around 11% of cardiovascular deaths were also caused by high blood sugar. As we know, neuropathy is also caused by high blood glucose level and high blood pressure. People with diabetes at a higher risk for foot ulcers and lower limb amputation due to neuropathy. That's why globally, diabetes-related foot complications are the third most common diabetes complication after heart disease and chronic kidney disease. And for diabetic retinopathy among people with diabetes, 22%, but it varies, no, among different countries. High-income countries tend to diagnose diabetes diabetes earlier. But how about those low and middle income country? So the prevalence of diabetic retinopathy is lower in resource constrained setting, where the diabetes diagnosis is often made complication have already occurred. As we all know, when a person is diagnosed with diabetes already exists 5 years or 10 years ago. That's why a call, not to everybody, just like Dr. Jimenez telling us that they must expand the coverage, the screening coverage of their country as well. Okay? And also the kidney disease is due to diabetes caused by millions of deaths. Next slide, please. So 60% of higher risk developing for cardiovascular, 73% for MI, 54% higher risk of stroke, and 84% higher risk of heart failure. So early detection, screening is the key to delay any of this risk of diabetes complication. Next slide. On this slide, you can see complications develop silently. Chronic complications such as what I have mentioned progress slowly and often without obvious symptoms. So by this time, they are detected and irreversible damage has already often occurred. Next. Okay, so these complications may also lead to neuropathic pain, fatigue, disability, and many others. Physical limitation, restrict daily activities, mobility, and independence. So this resulted in lower functional quality of life. Next slide, please. As you can see in the study of Kolaric et al., next slide, it showed that respondents rated the domain of physical functioning as the lowest due to the problems with daily activity. Demanding therapeutic regimen, medical aid, reduced energy for daily activities, fatigue, poor mobility, etc. Okay? And psychological and social functioning was rated an average grade of quality of life, while environmental functioning was rated with the highest grade, which can be explained by patient having sufficient financial resources for their needs. So overall, the quality of life was rated the worst in patients who had multiple chronic complications, while those without any complication graded their quality of life the highest. So therefore, we know that chronic complication is caused by poor glycemic control and lack of self-management skills increase the risk of these complications. Hence, we, the diabetes educators, the nurses, and all the healthcare team has a key role to prevent the complication. Another study, please, on the next slide, in the Cho et al., it showed that severity of hypoglycemia, efficacy of self-management of diabetes, self-management skills are factors that affects the quality of life. So hence, primary role of diabetes educator, or we call them diabetes care and education specialists, is critical, is crucial, and important for early interventions. Next slide. A survey was conducted with 222 young adults with type 1 DM, age 18 to 35. So most respondents reported an average level of satisfaction with life. Here, life satisfaction is influenced by additional disease such as hypothyroidism, hyperthyroidism, and any other diseases, while patients with higher hemoglobin A1C were associated with lower satisfaction with life. Conversely, modern monitoring treatment technologies improve satisfaction with life in young adults with type 1 DM, as reported. However, our traditional approach nowadays to persons with diabetes is no longer sufficient. It's no longer enough. That's why the digital transformation is the key to cover everything and to expand our interventions to all people with diabetes. However, there is a downside of using a technology, as we all know. One of that is we might ask who is the owner of the data because of so many digital technology nowadays. That's why one of the that I heard from the ministry is that digitalization also plays a key role here, because we need to have one data of all persons with diabetes so that healthcare professionals can automatically give care to their patient once they have an access to this data. In another study by Sri Lekha 2025, it was found out that sleep disturbances primarily because of insulin injections, special diet, involvement in physical and social activities reduce the likelihood of sleep disturbance. So the possibility of sleep disturbances is increased by unhealthy behavior, therefore reported as having poor life satisfaction. Next slide. Next slide, please. In the study of Mora's diabetes empowerment scale was used to 763 individuals as the final sample. It showed in their study that empowerment is moderate and the level of knowledge were slightly lower among people undergoing insulin therapy, but much lower among people utilizing other therapeutic approaches. According to the study of Ribeiro et al. In 2020, it was also reported that diabetes represents a psychological burden with the ability to negatively affect people emotionally, physical, and social domain. Also, people aged 65 years old or older, those with lower academic level, and those who self-reported disease complication perceive worse quality of life. So therefore, in conclusion, literacy and empowerment are important for the improvement of quality of life of people with diabetes, enabling them to manage their health condition and delay complications. We need to focus on education, just like Dr. Dina Mariani mentioned a while ago. We need to focus on education. Increasing patient knowledge and empowerment may contribute to better health outcome. Next slide. So what model can improve population health with chronic condition? I see on the slide of Dr. Jimenez a more detailed about this. But what is a chronic care? No? What is a chronic care model? No? American Diabetes Association actually recommend the approach to diabetes management in primary care be aligned with a chronic care model. So there are 6 components of this chronic care model. The health system, this is the structure, the leadership, and the culture of the healthcare system, which prioritize high-quality chronic illness care. So the system should support improvement through clear policies that was mentioned a while ago by one of our speakers, resources, and leadership commitment. But what are the 6 components of this? 1 is the delivery system design. This delivery system design have now moved from reactive to proactive care delivery system. From doctor-centered visit to team-based care that provides proactive follow-up and regular monitoring. This is where we come in, nurses and other healthcare professionals, the self-management support. We empower the patient to take an active role in managing their condition by teaching self-care skills, goal setting, and problem-solving strategies. So as diabetes educator, teaches patient on how to monitor their blood sugar, follow up a meal plan, recognize signs of hypoglycemia, and also to set a weekly goal for diet and physical activity. Decision support is the third, It's a clinical encounter. Every interventions that we do to our patient must be evidence-based. It should be current. It should be updated. And if necessary, should be coupled with technology as prescribed by the doctor, especially in controlling the diabetes, especially to have a timely intervention to patient, using whatever technology is recommended. Then the fourth one is the clinical information system, no? The registry. This is what I am telling a while ago, no? That we must have one registry of all persons specific and population based, no? To all support team to those persons with diabetes so that we can provide automatically the care that is given to our patient. Organized system of collecting is important, tracking, sharing patient data to support effective care planning and evaluation. That's why I think most of you in the Philippines also, no, and in other countries, we already have the electronic health record. And we already also have some of the doctors, what they call the electronic medical record or the EMR. This is a good technology where the registries, no, can be controlled and can be tracked down with the integration of all healthcare professionals in the use of EHR. Okay, and community resources and policy, no? We develop resources, we collaborate, no, to support healthy lifestyle, or we lead the people with diabetes to the programs existing in the community, like exercise, no, like nutrition classes, peer support group organized by the community health center or NGO in the local government unit. So it is very important that patients should be informed and should be actively participating in all interventions with the prepared, trained diabetes care and education specialist or diabetes educator, so we can be functional and would get a higher clinical outcome. Next, please. Next slide, please. Here in that study of Go et al., the chronic care model intervention compared to the usual care improved glycemic control among adults with type 2 diabetes in primary care setting, with greater reduction when the mean baseline of hemoglobin A1C is more than 8% and with interventions containing 4 or more CCM elements. So, therefore, next slide. What is diabetes self-management support? In the previous discussion, empowerment and self-care skills are vital components in managing diabetes, a chronic condition that demands continuous lifestyle adaptation and active participation. One CCM key component is self-management support, just like what I have mentioned, which directly aligns with diabetes self-management education support, a structured approach to help individuals with diabetes gain knowledge, skills, and confidence to manage condition effectively. Next slide, please. Okay, so here, diabetes self-management education and support is a process, no, that we facilitate the knowledge of a person with diabetes, their attitude, their behavior, no, their ability necessary to manage, to self-manage, no, their condition. So in DSME, we support informed decision-making, self-care behavior, problem-solving, and active collaboration with the healthcare team to improve the clinical outcome. So in the study of Ernawanti et al., based on the 15 articles on diabetes self-management intervention, it has shown to be effective in dealing with type 2 diabetes mellitus. And furthermore, DSME has shown positive effect on lifestyle changes and the self-care of type 2 DM patient. Such an increase in knowledge and adherence to diet therapy, exercise, glucose monitoring, and wound care. In line with that, another study explained that DSME significantly improved medication adherence, self-management behavior, knowledge, and self-efficacy, and quality of life. Next slide. So in doing the diabetes self-management education, a collaborative or interprofessional team should come together, bring together multiple disciplines within the healthcare system. They are best suited to provide care for people with chronic condition. Who are these? These are the pharmacists, medtech. These are the nurses, the doctors, no, social workers, and other dietitian, no, registered dietitian, no. So all of these are important, which centers around the person with diabetes. So therefore, we should avoid therapeutic inertia and prioritize timely and appropriate intensification of behavior change. Pharmacologic therapy, nutrition, and other financial support system to individual who have not achieved recommended metabolic goal or target goal of patient who are experiencing a high burden of treatment. It is also in the study of Nurkis et al. 2022 in a systematic review of data from the databases, no? It shows that out of 961 papers initially retrieved, 19 papers, no, were included. It was reported that interprofessional collaboration is significantly associated with increase in both patient satisfaction and in the mental well-being component of higher quality of life. And it is a promising evidence supporting the association between the interprofessional approach and an increase in self-care and specific quality of life. Next slide. Therefore, with the combined effort of discipline, together we must build positive health behavior and maintain psychological well-being. These two are foundational for achieving diabetes management goal, maximizing quality of life. Essential to achieving this goal are diabetes self-management education and support, or DSMES. Person-centered collaborative care is guided by shared decision-making in treatment plan selection, facilitating access to medical, behavioral, psychosocial, technological resources, and support, and shared monitoring of agreed-upon diabetes care plan and behavioral goal. Next slide. So, diabetes self-management education and support, or the DSMES, is structured around 7 diabetes self-care behavior, or known as the ADSES 7, or the self-care behavior. So here on the 7 key self-care behavior, it encompasses the healthy eating, being active, taking medicine, monitoring blood sugar, reducing risks to lower the chances to diabetes, healthy coping, no, problem solving to find solution and take action. And this is where we, diabetes educator, should assist patient with diabetes. Next slide. What is being active? Being active means doing any type of daily physical movement, whether it's structured like a session of exercise or whether it is unstructured like anything that decreases the time you spend sitting. Fit activity into their daily life. When it's hard to find the time or motivation to start being active to persons with diabetes, you need to incorporate, no, or to integrate the best way to fit the activity into their daily life, whether it's walking more, doing chair exercises, or working out at the gym, or anything that makes them enjoyable. Taking the stairs, for example, instead of elevator, finding a gym buddy, for example, no? Or call a friend for go dancing. Any form of being active is recommended, no? So this would also reduce, no, the blood sugar of patient. Next slide. Okay, next slide is taking medication. Okay, so as diabetes education, no, Taking medication is very important, just like one participant asked the adherence of medication, right? So it helps lower the risk of heart attack, stroke, kidney damage by managing the blood glucose, blood pressure, and cholesterol level in our body. So it is our responsibility as diabetes educator to know any side effects that the patient are experiencing. Have they stopped taking any medication because of the side effects? This is our role. So we need to know their life experiences in their journey having diabetes, especially those with chronic complication. So if the medication is affecting the quality of life, no, we need to plan together with them, with the team, okay, so that this would resolve the problem. Checking medication plan if it is also working. Diabetes care and education specialists like pharmacists, nurses, dietitian can be a great resource when it comes to understanding the medication plan of our patient. They can help you find assistance program if necessary, because all the profession and discipline as they work together, no, there would be improvement in the clinical outcome and also in the quality of life of our patient. Next, healthy coping. So a diabetes care and education specialist can also help us figure client costs of stresses. If you have a chronic condition, most of our patient really is undergoing stress. So therefore, if one is under stress, it affects the self-care of a patient. So together with the patient, we can develop a healthy or positive coping strategies that work best and fit for them. Okay, next slide. Another component of self-care behavior is the healthy eating. Here, the assistance of a registered dietitian is important and vital. Like, for example, teaching our patient, no, skills must be taught about measuring food to get familiar with the portions, determining the correct portion for that person, reading labels, timing meals with medication, being aware of counting the carbohydrates food you eat, better understand the impact of all of this on their blood glucose. Okay? Aside from healthy eating, we also have another component on how to reduce the risk to lower the chances of diabetes complication. Next slide. Reducing risk means doing behavior that minimize or prevent complications, negative outcomes of pre-diabetes and diabetes. So taking to diabetes care and education specialists about health risks such as kidney damage, nerve damage, no, and vision loss is very important. So probably you schedule regular medical checkup, monitor, get screened if patient have episode of sleep apnea, and then get screened for hearing loss, no, because this may affect also the satisfaction of the patient. Follow your healthy eating plan, help our patient to follow it, commit, move, and sitting less, no, take medication as prescribed. We also have to monitor their blood glucose using CGM. But CGM is a little expensive. It's expensive, and only those who have the capacity, okay, to purchase CGM can monitor strictly, no, in a timely manner their blood glucose. And there is another way of translating this result, no, and transferring it to the healthcare professionals, no. So again, don't smoke or vape. This is a no-no to a diabetes patient. So we need to educate them more of this, which contributes to neuropathy. Brush and floss your teeth daily is also important to be reminded of our patient. Get a flu shot, especially to older person. Get pneumonia, hepatitis B vaccination. Discuss any sadness or distress with a diabetes educator. And we need to remind our patient to check their feet daily for any redness, sore, or even open wound. Okay, next slide. Another component of self-care behavior is monitoring. Okay? Monitoring means checking the glucose of our patient, glucose level of our patient. No? Activity, food intake, gathering data from multiple sources and devices that they have, and make decisions about their diabetes prevention effort or diabetes care and self-management. In monitoring, they should know the numbers. Okay? Knowing the numbers, like for example, knowing the optimal target that ranges to aim for a patient because it varies from one patient to patient. It depends on the age, it depends on the complication that is somehow recommended by the physician. For our client, it's our role to facilitate or assist them to target their number. So diabetes target differently because it is individualized, the plan is individualized. We need to balance the benefit of strict control with the risk of complications, patient safety also, and the quality of life. And we need also to choose the monitoring device that is also working for the patient. Because some of the devices are expensive and some of the patient in the lower and middle income countries cannot afford these devices. We go back with a simple technology or what we call the SMBG. So monitoring devices provide data that helps client know if diabetes management is working. However, in SMBG, it depends also on the strip, how expensive it is. So again, this is a barrier again. So diabetes care and education specialists should, in choosing devices, for example, consider the affordability of the patient as well. If they don't have these devices, I think the primary care setting in the local government unit have these devices which they can visit in the primary care setting. The third one is they should know how to find the pattern. So let us educate them, or sometimes they themselves can experience it and they themselves can share this experience to you, like taking multiple measurements and putting them together to identify pattern. Example, the patient might see pattern that their glucose is higher after dinner on most days. Or for example, if the patient would take exercise or walk for 20 minutes, they experience hypoglycemia or their glucose goes down probably on a better level. Okay? So monitoring is vital. It's important that diabetes educators should make follow-up to their patient. Next slide, the last of the self-care behavior is problem solving. Okay. Diabetes change over time, so client may need new ways to manage it. Sometimes a patient may take an oral glycemic, and suddenly it is shifted to insulin, and suddenly there exists another complication. So therefore, it changes over time, and we should assist our patient in problem-solving technique that can help them live well with diabetes. So a diabetes care and education specialist can guide and support our patient through developing a plan to prevent problems, even in the future. First is we need to identify the problem. So there must be a consistent or constant follow-up to diabetes educator. So that, for example, if a patient will have a flu, for example, and notice that the blood sugar level becoming higher. So what do they do? Okay. For example, they have into vacation in other country. You don't have easy access to the gym or time to exercise, for example. How will you handle this type of situation? Like for traditional food, you have a hard time finding healthy food choices with your family due to cultural or taste preferences. What step can you take? Okay, so these are some of things that we need to identify to our patient, to persons with diabetes, because sometimes they do not know what move or what step should they go because they are not that motivated, okay, and they may not have that sufficient knowledge, okay, to do more to do on research or to decide on matters particular to the challenges that they have experiencing. And the second one is to find solution. So know any issues that the client are experiencing, like not being able to afford all diabetes medication. But I know, no, in the government, no, they are already giving free medications, insulin, okay, to those who need it already. But however, what they do not know is where will they go? How will they collaborate? To whom should they ask? Okay, so all of this is our role as diabetes educator. We also need to validate information from them that can help come up with the right solution to the problem. And therefore, the third step is to take action. We must choose how to solve the problems once you have an option. One reason and barrier of patients with diabetes is that they cannot see any option, especially in the low and middle income countries. So therefore, as a diabetes educator, we must set a realistic action plan or assist them, okay, of several options that they can choose upon. So we need to pick a solution that they can handle, get help if necessary, check to make sure your solution really works, and try something different if one solution doesn't help the patient. It's really expanding. The role of diabetes educator is expanding because we are all geared toward a specialization. Therefore, a diabetes educator or diabetes care and education specialist, no, can be qualified depending on the submitted qualifications, whether they are aligned with level 6, level 7, or level 8 on the qualification framework. So it is necessary also that diabetes educators must have an intensive training or course or short course training, practices, also come up with researches, also practice hours in the primary setting or even in the hospital. All of this contributes to the qualification of a diabetes educator, which turn on to be aligned with what level in the qualification framework. And this equates also the salary of a diabetes educator. And again, this is the recommendation of diabetes self-management, next slide please, and support in 2024. According to ADA, all people with diabetes should be advised to participate in developmentally and culturally appropriate diabetes self-management education and support to facilitate informed decision-making, self-care behavior, problem-solving, active collaboration with the healthcare team. DSMES should be culturally appropriate and responsive to individual preferences, needs, and values, and may be offered in group or individual setting. Next slide. Another recommendation in the DSMES is that we must provide DSMES at the time of diagnosis, annually or when not meeting treatment goal, when complication factors already develop, and when transition in life and care occur. And consider also offering DSMES via telehealth. There are so many nowadays, and digital interventions as needed to meet individual preferences. Okay. We also have the virtual reality nowadays that can be also used in the community setting as the latest and updated technology that we can use as a form of educating our patient. However, it's very expensive. Okay? And also we need to address barriers to access and improve satisfaction of our patient. When they are satisfied, it improves the quality of life of our patient. We need to identify and address barriers to DSMES that exist at the payer, at the health system, clinic, healthcare professional, and individual system, especially when you are using the EMR, using the electronic health record, and other technology which our patient have access for consultation. And then screen for and include social determinants of health in guiding, design, and delivery of DSMES with the ultimate goal of high quality across all population. So in summary, okay, diabetes mellitus remains a major global health challenge that significantly affects both population health and individual quality of life. The global burden of diabetes continues to rise and at an alarming state, with the highest prevalence observed in low and middle income countries, where access to preventive care and diabetes education is often limited. Evidence consistently support that the chronic care model provides an effective framework for improving outcomes among individuals with diabetes. Research also highlights that structured DSME improve access to health services, early detection of complication can markedly improve both metabolic control and quality of life. Research, next slide, also affirms that DSME guided by self-care behavior, healthy eating, being active, taking medication, etc., okay, enhances self-efficacy. Treatment adherence have been shown to lower hemoglobin A1C level, reduce hospitalization, and improve quality of life among people with diabetes. Diabetes care specialists or diabetes educators, no, we play a crucial role in improving health outcome, enhancing self-management skills, and promoting overall quality of life among individuals with diabetes. Let me end this discussion by saying patients are empowered when they have the knowledge, when they have the necessary skill, when they have the correct behavior and attitude, and self-awareness necessary to influence their own behavior. Thus, it improves their quality of life. Here are my references, and thank you for giving me an opportunity to contribute in today's session in the attainment of your goals and objectives.
Okay. Thank you so much, Ms. Anjanette, for your inspiring presentation. You reminded us that empowering patients is one of the keys to achieving better health and also to get a better happiness. Now, we open a Q&A session for the second plenary. Feel free to type your question in the chat or raise your virtual hand, and let's take this chance to learn and interact with our amazing speaker. And we have received several interesting questions from our participants in the chat box. Let's take a few of them and hear the response directly from our speaker. Can you share the screen?
Hi. Sorry, I cannot hear much, but it is here in the chat. Okay, one of the question is, may I ask why are the blood sugar monitoring results using a peripheral blood specimen different from the one obtained using a CGM? What factors may influence these differences, and how accurate is CGM compared to laboratory plasma glucose? Okay, thank you for that question. No, the plasma glucose still, no, is really the best way, or the fasting blood sugar is still really the best way for us to see the accuracy, okay, of our of blood sugar. Okay, in the CGM, same with the peripheral blood specimen. In the use of CGM, there are other factors and barriers, because some of the reasons probably is because of the priming, because of the connection, no, the connection from the connection from the control, and then also the transducer. There are different factors actually, and actually there must be changes of this, no? The one attached to your body should be changed somehow weekly, okay? Because sometimes it varies, no? It varies the taking of blood glucose in our body. Again, there are different factors why. No, sabi natin, as we said, there is a downside in every technology. And therefore, the diabetes educator must be in support and educate the people in the use of the CGM.
All right. Is it clear, Ms. Santi? I think it's already clear. Now we will move to another question. We have several questions for Dr. Zhou. First one from Ms. Eliati, a dental therapist lecturer. Her question is, what are the factors that cause the highest incidence of diabetes in Timor-Leste, and why does it occur most frequently in women? Is there any community empowerment to assist in diabetes prevention? 3 questions in a row. You may answer now, Dr. Zhou.
Okay. Thank you, Ms. Kaviati. Thank you for the question. I think I already mentioned it in the presentation, but of course, I can say it again here. First of all, the factor that caused the highest increase of the diabetes in Timor-Leste, I think it's the change of the lifestyle of Timorese people. We just exposed to the recent lifestyle, I don't know. So our activities actually increase, but the activities not happening in the proper and correct time, like Dr. Janet from mentioned the name. Sorry. So like many activities that we do basically it's having fun, but it's not the correct time place. So something that happened in the I think in the proper time and place will lead to the worse condition. So the other thing is the I would not say the lack of knowledge, but I mean maybe insufficient knowledge and awareness about the diabetes. It fits our people to not aware about their diabetic condition. So they don't want, they don't use to go to check up their health status in the health facility. They still stick in the conventional cultural ways and also belief. We consume food that have the very high sugar or carbohydrate concentration. So Timor-Leste, we eat every day with rice, maybe 3 to 4 times a day. And outside that we still have our snack, mainly composed from the carbohydrates, also the lipid. So some of us maybe consume junk food recently. So the lifestyle become the major factor that increase our diabetes status in the country. And about the why women higher than men in the country, maybe it's because of our cultural also. It's or the fact that women in Timor-Leste, by the culture and also our belief, the reality is Timor-Leste women, they get more often to have babies pregnant rather than maybe Indonesia, something like country like Indonesia. Just have 2 or 3 kids, but Timor-Leste, we say that 3 is not enough, 5 is good, but 7 or 8 is better. So it's increased the risk for the diabetes national epidemic. And we know that during the pregnancy period, the access to the consumption of food is increased because of the needs. And other thing is almost 70% of our population that they live in the village and rural area. We have the problem of about the living conditions. Women, they stay in house, very afraid to access the health service for their own health state. So mainly they care about other person, their kids, and also sometimes their husband. But for their self, they lack of this awareness. So this is maybe the lead to the why women in Timor-Leste have higher risk than men related to the diabetes problem in Timor-Leste. And of course, we are trying to empower our community by bring them together in our system. What I just mentioned in the presentation, we call about the peace, Pacote Integrated Saudi, or the integrated health package that we conduct in the community, among the community. So we conduct in the villages, we conduct in the Dusun, Aldea, in Aldea. So as Dr. Aneta mentioned, that this is not a single fighter approachment, but it's a team approachment. So among the team, the leader of the community, the the focal point of health, focal point in the village, in the community, also included in the team. So before the team from the health facilities come to this specific community, all the information or some activities that will be done by the community leader and also the health focal point in that area. I think that's what I can say. Sorry. Yeah, thank you.
Okay. Thank you, Dr. Zhao. Now we will move to another question.
I see in the chat box.
Wait a minute, the screen is still loading. Another question from Sharifah. She is from Stikas Cirebon, and the question is, would you like to elaborate more about what tool is used by Timor-Leste in diabetes screening? Do you like to answer it now?
Thank you so much. Yes, I think this the second and third question they just raised the same issue, that is the different collaboration. So I will try to answer these ones. I hope that both of them can get what I try to explain. So the Timor-Leste, we are adapting or we applying the tools that elaborated, developed by the WHO. We call it stepwise approach. So it's a WHO tools that we uh, contextualize to our vision, Timor-Leste vision. So any tools, as Dr. Junaid mentioned, any approach should be contextualized so it can fit and then work properly. So in this stepwise wise that we use to uh, screen the diabetic patient in Timor-Leste, it's both three main activities or three main aspects. So first, it's talking to community using proper questionnaire question to be elaborate systematically. So about the behavior uh, related to the diabetic risk factor. So by the questionnaire, we sit with them or maybe the team conduct it, we can get at least uh, roughly, so we know that who are the risk, who the in the risk of the diabetic disease. The second one is the physical examination, physical measurement. So we do the blood pressure measurement, we weight measurement, and also waist measurement size. So by that, we can uh, assume someone to put them in the risk of a diabetic person or not. So this, and then second and the third one is a biochemical measurement. So we do we do the rapid blood glucose test. We use very simple tool that we do this not only in the health facilities, but also in the among the community once we conduct this program there. So uh, and we can check the testing of uh, fasting blood glucose or blood glucose that we do this by the time we conduct this program or once they come to the facility. So with these three simple ways, we already catch many our community that get diabetes problem. For example, like in my health facility, where I work, just in 2 months, I register from the almost 500 people who are meet the requirement for screening for diabetes and also hypertension. Start from the 18 years old for the hypertension and the 30 years old of our product sales. From the 500 something like that in 2 months, I we cut up into the 212 patients that get the diabetes problem, also hypertension problem facilities where I work as a medical doctor. So this is a simple one that fits to the our situation in Timor-Leste. So with the empowerment of our community, the community leader, also health focal point from the community. So we expect we can increase the coverage of diabetic and also hypertension screening here in 2025. Thank you so much.
Okay. For me, Sharifa, is it clear? Or do you have further question? We will next to another question. We still some few question, Dr. Zhou. Now this question is about how to ensure its effectiveness, about comprehensive monitoring framework. So could you highlight which indicator poses the biggest data collection challenge in the Timor context, and what specific strategies are planned to guarantee data reliability from remote communities?
Thank you so much. The data collection and also data management is remains a big challenge for us. I would like to say that from my own experience, I would like to say that what I did in my daily practice in the health facilities. So in our policy for the intervention of the non-communicable disease, especially in the hypertension and diabetic disease, we apply what we call the cash for the NCD for the pain patient. It's mainly only for the hypertension and diabetic patient. So with that passport, even it's still manual, but we track the patient, we track the people for screening, and also while on TV we put in the system for the clinical intervention. We follow them through this very simple hard passport. It's just two paper. So we give it to the patient, and we also register them in our system. Even it's not electronic, we are trying to establish the electronic one. As I mentioned before, this is the new approach that we are piloting now in at municipalities. So after 2025, the activity will scale up and we will implement it for the whole country. So after December, we will gather together, we discuss, and then we give all the ideas together to improve our intervention for the diabetic hypertension problem in our state. So I have to confess the data surveillance data especially, it's remain our biggest challenge. Now we are trying very hard to establish certain good data set application for all health systems. I think that I can say for this one. Thank you.
Okay. Well, actually we still have many great questions in the chat, but due to time limitation, we can only address 3 of them today. And for the remaining question, maybe Dr. Zhao or Ms. Anjanette as our speaker may kindly respond later through email, or maybe the committee may compile them for post-event sharing.
Sure.
Thank you so much for your active participation, for all the audience, and also for your throughout-full question. It's been a truly engaging and also inspiring session. And to close this ceremony, to close this session, we will have the certificate of appreciation for our last 2 invited speakers. This certificate will be presented with the same person, which is Vice Director 1 of Health Polytechnic, Ministry of Health, Tasikmalaya. To Dr. Asep Kuswandi, Bachelor of Nursing, Nurse, Magister of Nursing, and Specialist in Surgical Medical Nursing, please join me in congratulating both of our speakers.
Oke, Miss Kanita. Assalamualaikum warahmatullahi wabarakatuh.
Salam Bapak.
Okay, distinguished speaker, respected participant, and honorable guests. Good afternoon and warm greeting from Poltekkes, Kemenkes Tasikmalaya, Indonesia. On behalf of Poltekkes, Kemenkes Tasikmalaya, I am honored the present this certificate appreciation to Dr. Jauh Manuel Kore Simmons, MKM from
Thank you, sir.
Universidade Dili, Timor-Leste, as invited
Terima kasih.
speaker 3 for plenary speak 3 entitled Public Health Strategies in Preventing and Reducing Chronic Diabetes Complication at ICHET2025. Thank you for your valuable contribution and please accept this certificate as a sign of dedication and appreciation for your effort in knowledge sharing.
My pleasure, sir. Tur nuhun.
Oh, sami-sami. It's exciting. I think you are orang Sunda, ya, Sundanis.
Dulu di Bandung,
Oh, I
Bapak.
see. Oh,
Dari Maranatha.
oh, Maranatha, I see. Yes, sometimes it is very great if you come to Tasikmalaya. Yeah, it is not too far from Bandung.
Yeah. I appreciate. Thank you so much.
Yeah, my
There
pleasure.
is one more for
Yeah.
Miss Anjana.
And okay, and on behalf of Poltekkes Kamsaya, I am honored to present this certificate appreciation to Ms. Anjanet S. de Leon, MAN, RN from Central Escolar University, Philippines, as invited speaker for this plenary speech entitled Empowering Patient Managed Chronic Complication and Enhance Life Satisfaction at ICHET 2025. Thank you for your valuable contribution and please accept this certificate as a sign of dedication and appreciation for your effort in knowledge sharing.
Thank you. And thank you also for the opportunity having me on this fifth conference. Congratulations.
Yeah, thank you. My pleasure, Ms. Anjanet.
Okay. Thank you and give another round of applause for our distinguished speakers. Ladies and gentlemen, that brings us to the end of today's plenary session. Now it's time to announce the winner from our participant who asked a question, and congratulations to the winner. Can you share the screen? Who is the winner? There are 4 winners. Okay, once more, congratulations. And please don't forget to contact the committee to claim your prize, or maybe the committee will contact you as soon as possible to get your phone number for GoPay voucher. And on behalf of the organizing committee, I would like to thank all our invited speakers for sharing their knowledge and also experience. Thank you also to all the participants for your enthusiasm and attention. May today's discussion inspire us to work together to improve diabetes care and promote better health for all. I'm Kanita Wulandara, your moderator, signing off with warm regards. Stay healthy, stay positive, and see you in the next international conference next year. Thank you very much, everyone.
Okay, thank you so much to our moderator, Ms. Kanita Wulandara, for your valuable contribution and dedication throughout the session. And now we will proceed to the certificate presentation, which will be presented by Vice Director 1, Mr. Asep Kuswandi, Bachelor of Nursing and Magister of Nursing, Specialist in Medical Surgical Nursing. To the Honorable Mr. Asep Kuswandi, sir, you may now kindly present the certificate.
Okay, thank you. On behalf of Poltekkes Kemenkes Tasikmalaya, I am honored to present this certificate of appreciation to Ms. Kanita Wulandara, SST MCAP, for excellent role and contribution as moderator at ICHET 2025. Thank you for your dedication and support, and please accept this certificate. Hopefully it will encourage you. Thank you.
Okay, thank you very much. Okay, thank you very much, Mr. Dr. Asep Kuswandi and also Ms. Kanita Wulandara. We would also like to extend our sincere appreciation to all distinguished speakers from sharing their valuable knowledge and insight during the plenary session. With that, we officially conclude our plenary sessions. Ladies and gentlemen, we will now take a break for lunch until 1:30 p.m. Western Indonesia time. And before we take a break, please fill out the attendance link provided by the committee. Please use this time to refresh yourself and get ready for the upcoming parallel presentation sessions. We look forward to reconvening at 1:30 p.m. on time. Once again, I would like to inform to all participants to fill out the attendance list before we take a break. We look forward to reconvening at 1:30 p.m. on time. Thank you.